So good morning, students. Happy to see you all on Sunday morning. I hope you are all studying well. So we'll have a short revision in ENT. So last year I did this revision. Almost 90% of the questions asked from this PDF alone. Okay. So your whole book, which I'm having around 20 to 50 pages, it's a big material, but this around 70 pages material itself, they asked a lot of questions. Around 90% of questions were asked. Only one or two questions were left off. So that's why. So the team has asked me to continue the same revision. Okay. So first we'll start with ear, then nose, then throat. Okay. So if you have any technical issues, any audio issues or video issues, you could tell me. Okay. So first we start with anatomy and physiology of ear. So embryology of the ear. They asked embryology of the ear 2 questions last time. Okay. So pinna develops from, so this one due to some PDF conversion mistake, just come like this. First and second pharyngeal arch. Second arch, mesenchyme, which develops into hillocks of ears. One thing you want to make very sure that, see, the embryology of ear is very simple. External and middle ear forms from pharyngeal arches. Inner ear forms from the neural ectoderm. Neural ectoderm is divided into two: otic capsule, otic vesicle. So otic capsule will form these structures. Otic vesicle will form these structures. It's very simple. Okay. So external middle ear, separate embryology. Inner ear, separate embryology. That's the important point that you people need to understand. Okay. So pinna develops from hillocks of his first and second arch mesenchyme. External auditory canal develops from first pharyngeal cleft. Middle ear cleft initiation forms from first endodermal outpouching. Okay. A tympanic membrane forms from all 3 layers. Malleus and incus forms from together with malleus and incus together with tensor tympanic muscle. Forms from first arch mesenchyme. The stapes forms from second arch mesenchyme. Okay. The bony labyrinth along with stapes footplate and anal ligament forms from otic capsule. Membranous labyrinth forms from otic vesicle. Alright. So this table is very important. Kindly make a note of it. So ear anomalies and symptoms. So first, the first and second arch mesenchyme, which forms the pinna, develops from 2 origins. There is first arch mesenchyme and second arch mesenchyme. So the fusion point between the first arch mesenchyme and second arch mesenchyme will sometimes be a remnant after birth. That remnant is called pre-auricular sinus. Can you see here? So this will be the first arch origin. This will be the second arch origin. The fusion point between the first arch origin and second arch origin will remain as a sinus even after birth. So this is called pre-auricular sinus. Okay. So if the patient has first discharge from this sinus, you should do surgical excision. If it is asymptomatic, don't do any surgery. Then another disease is called coloral fistula. Coloral fistula. This coloral fistula is the first ectodermal cleft defect. See here, one opening is at the floor of the external canal. The next opening is at the angle of mandible. Floor of the external canal and angle of mandible is the coloral fistula. Coloral fistula. So the questions which were asked from the last FMG here. So what is the structure and which is the origin of this particular structure? So this is malleus, this is incus. So malleus, incus come from first arch mesenchyme. I already told you. Okay. So the question was asked from last FMG. This one is exactly the pre-auricular sinus which I just discussed. Okay. The first page of my PDF itself contains 2 MCQs from last FMG. Okay. So this page just I added just now. Okay, the PDF which I gave last year remains the same. I didn't change anything. So the first, the arrow congenital anomaly develops due to non-fusion of. So first arch mesenchyme and second arch mesenchyme due to incomplete closure forms pre-auricular sinus. The word pre-auricular sinus is not given over here, but this picture shows pre-auricular sinus. Alright. So this you don't have to study too much. You just have to remember that. So if there is a Treacher-Collins syndrome or golden hair syndrome, these syndromes happen due to first and second arch defects. Okay. So this happens due to first and second arch defects. Okay. So conductive hearing loss. It causes conductive hearing loss. Okay, let's get into important anatomy of ear. So I've just given some important points over here. Please make a note of it. Middle ear anatomy is divided into 6 dimensions: lateral wall, medial wall, anterior wall, posterior wall, and roof and floor. So lateral wall is very easy. Scutum is the bony projection from the superior aspect from the temporal bone to which the tympanic membrane is mounted. So scutum they may ask. Tympanic membrane, it's having 2 parts, pars tensa and pars flaccida. The cone of light is formed by umbu. The 5 o'clock question and the 7 o'clock question in respective years has cone of light due to some small elevation from the surface. It is called as umbu. Okay, fine. Anterior wall. So anterior wall, we will be having 2 canals. One is canal for tensa tympani, another one is canal for eustachian tube. The third one is canal of Hoogier, which is an exit point for chorda tympani nerve. Chorda tympani nerve is a bands of facial nerve which originates from the posterior wall, but it exits from the ear through the anterior wall through the canal of Hoogier. Medial wall is having prominence of cochlea, 2 windows, 2 bony projections, processus cochleariform is 2 bony coverings for facial nerve. Okay, so this one is very important. So let me show you some 3-dimensional anatomy for better understanding. So look at this anatomy. So medial wall of middle ear, as I told you already, you will have promontory, 2 windows, oval window, round window, 2 bony projections, subiculum and ponticus. So look in this picture. This is the medial wall of the middle ear. Can you see? So it's very easy to understand. See here, this is the promontory. This is the oval window. This is the round window. So from here you will see the ponticus. Here you will see the subiculum. So just above that we will be having facial canal. Canal for facial nerve. Just above that we will be having prominence of lateral semicircular canal. So promontory, 2 windows, 2 bony projections, 2 elevations. Okay. These are all the parts of the medial wall of middle ear. So prominence of cochlea from the inner ear is called as promontory, having 2 windows, oval window where foot bit of stapes gets attached, round window there is no attachment but there is small membrane that is surrounding it. We call it as secondary tympanic membrane. 2 bony projection, ponticus below the oval window, subiculum above the round window. Process cochleariform is an important landmark they may ask. So it's an attachment for tensa tympanic tendon. So tensa tympanic tendon is a tendon which is attaching to the malleus ossicle. So it is having attachment or origin from the anterior wall from the canal of tensa tympani and also from the medial wall. Processus cochleariform is very important point. Kindly make a note of it. Okay. tensor tympani muscle. Okay, fine. So 2 bony coverings for facial nerve and lateral semicircular canal. So one thing you make a note of it, the first pharyngeal arch is supplied by mandibular division of trigeminal nerve. So if they ask any structure and they ask the nerve supply now, you should write it accordingly. Mandibular division of trigeminal nerve. The second pharyngeal arch is facial nerve. Okay. Second pharyngeal arch is facial nerve. So this is very important. So the next posterior wall. The posterior wall, we are having an important bony ligament called pyramid. Okay, the pyramid is an attachment for stapedius tendon. Pyramid is an attachment for stapedius tendon. So the anterior wall is having attachment for tensor tympanic tendon. The posterior wall is having attachment for stapedius tendon. So we are having one space above the pyramid which is called facial recess. One space below the pyramid is called as sinus tympani. Okay. Roof, you have tegment tympani of temporal bone. Floor, you will have jugular bulb. Right. So we are having contents of the middle ear. We are having malleus, incus, and stapes, and 2 muscles. So malleus is hammer shaped. You look into this, they may ask this. It's a hammer shaped. How to identify differentiate between malleus and incus? Okay. So malleus, the head will be round like a hammer. Here it is flat. There is the difference. We are having small depression of the neck. There is no depression of the neck. Okay, that is the difference. So hammer shaped handle of malleus is making a prominence on the tympanic membrane is the next important point. Next one. The incus is anvil shaped, and the important point is the incus has the least blood supply among the 3 ossicles because it is not having any muscle attachment and also it is found in between 2 ossicles, so it is having least blood supply. It is more prone for erosion. Then we are having different parts of the incus. One is long process, short process, basic of malleus. Short process of incus makes fossa incudis, which is a surgical landmark for facial nerve. Short process of incus in fossa incudis, it makes surgical landmark for facial nerve. Very, very, very important. So look into the stapes. It is stirrup shaped. It is the smallest bone in the entire body. The foot plate of stapes, it is attached along with the ulnar ligament in the oval window. In the oval window. Here. So what are the muscles? The tensor tympani muscle. So origins from canal for tensor tympani and process cochleariformis. And the nerve is mandibular nerve. I have told you already. So first arch muscle. So mandibular division of trigeminal nerve. Stapedius, the origins from pyramidal eminence, posterior wall. So nerve is facial nerve. Okay, its nerve is facial nerve. So we have seen ample amount of concepts about the middle ears. Now we enter into inner ear, very important. So inner ear is divided. So basically you divide the inner ear into 3 compartments. So if you see a snail will be having like this node. Similarly, the same structure applies for this is a bony labyrinth. Within the bony labyrinth, you will have a membranous labyrinth. Within the membranous labyrinth, you will be having a sensory epithelium. So 3 compartments. Outside is a bony labyrinth like like a shell of the snail. Inside will be structures. So outside compartment bony labyrinth, middle compartment membranous labyrinth, inside there will be sensory epithelium. So you divide the inner ear into three compartments. One is bony labyrinth, next one is membranous labyrinth, third one is sensory epithelium. Alright. So we are having three functions from the inner ear. One is hearing, the second one is linear balance, the third one is angular balance. Okay. So I want to hear better. Cochlea is a bony labyrinth. For every bony labyrinth, there will be membranous labyrinth, be it hearing or linear balance or angular balance. So within cochlea, we will be having cochlear duct. Within cochlear duct, we are having sensory epithelium by name, organ of Corti, very important. So which is the sense organ for hearing? Organ of Corti. So what will be present in the organ of Corti? Inner hair cells and outer hair cells. So these are the important points. So vestibule is a bony labyrinth. Within the bony labyrinth of vestibule, we'll be having two important structures called atricle and sacral, which are the membranous labyrinth. The sensory epithelium of linear balance is called as macula. So let me write it down. So organ of Corti is for hearing. Macula is called linear balance. Crista ampliaris is for angular balance. So I have told you this organ of Corti will be having hair cells. Okay. So the hair cells is divided into two types: inner hair cells and outer hair cells. The inner hair cells, I compare it with the resident who works day and night in the tertiary hospital. So outer hair cells is like a resident. Inner hair cells is like a consultant. Outer hair cells is like a resident. Inner hair cells is like a consultant. So why? So the residents will be more in number, but they don't have any contact with the central management. So they are very vulnerable to every problems. Okay. So the type 2 outer hair cells is like a senior resident or junior resident. So they will be more in number. The type 2 or cylindrical shaped cells, they are more vulnerable but less contact with the central pathway. So they can't do anything. So what is the clinical significance of outer hair cells? So in a diagnostic test called autoacoustic emission, this outer hair cells is very important. So this autoacoustic emission will detect energy release from which part of the ear. They may ask this question. So you should tell it as outer hair cells. Outer hair cells. So what about inner hair cells, sir? So inner hair cells are less in number. They are type 1 or flask shaped cells. Okay, they are less vulnerable, but contact with central pathway is to cochlea now. So like consultants has direct contact with the hospital management. Similarly, so this inner hair cells will have contact with the central pathway. Okay, so it creates ionic gradient and produces endocochlear potential. Creates ionic gradient and it produces endocochlear potential. Okay. So then the most important part, physiology of ear. So how the auditory pathway. So physiology of ear, they are nothing but auditory pathway. So just remember this mnemonic ecolema. The sound from the outer hair cells reaches the inner hair cells. From the inner hair cells, it reaches the eighth nerve. So E for eighth nerve. Then cochlear nucleus. Okay. Then superior olivary complex. Then lateral lemniscus. Then inferior colliculus. Then medial geniculate body. Then auditory cortex. Okay. So ecolema. Eighth nerve, cochlear nucleus, superior olivary complex, lateral lemniscus, inferior colliculus, medial geniculate body, auditory cortex. It's very simple. Yeah. Next, there is a concept called impedance matching. Okay. So the most of the atmospheric sound will get dissipated. It will not reach the inner ear. To match the dissipation of the sound, the ear is having a natural mechanism to amplify the received sound. For example, the room which you now live will not be the same if impedance matching is not there. Okay, this impedance matching will increase the sound to 22 times. So the 22 times the sound is increasing. Alright, how it is increasing? First, we consider the length of the malleus with the length of the incus. If we consider the length of the malleus with incus, the length of the malleus is 1.3 now. The length of incus is only 1. For example, if the malleus is having 13 millimeter length now, incus will be having 10 millimeter length. So malleus is comparatively lengthier than incus. So what is special in that, sir? It is special that if we transmit sound signals from a lengthier rod to a smaller rod, the efficacy increases. I'll repeat it. If we transmit sound from lengthier rod to smaller rod, the efficacy increases. This is called lever ratio. You'll get 1.3 times betterment with this ratio. Okay. Next one is area ratio. Just compare the area of tympanic membrane to the footplate of stapes. This is the starting point. This is the ending point of the middle ear. So this effective vibratory surface area of the tympanic membrane is around 55 millimeter cube. The effective surface area of the footplate of stapes is around 3.2 millimeter cube. Okay. So when we compare the surface area of these two areas, starting and ending, we'll get a ratio of 17:1. Okay, 17:1. So when multiply 17 into 1.3, the total we get is 22:1. If they ask by impedance matching, how much amplification will happen to the atmospheric sound? Now, the answer is 22:1. It's very, very important. Clear? Next, we'll be having important tests. So they are asking a lot of tests also. Two diagnostic tests they have last time. The first test is Rinne's test. Just look into me. So this test is found at the lateral part of the ear. So first, I should strike the tuning fork, place it behind the ear, master process. So ask the patient whether you hear the sound, and you should signal me once you stop hearing. Once the patient says, I have stopped hearing over the master process, you should remove the tuning fork, place in front of the ear. So if the patient says that still I could hear better, which means that air conduction is better than bone conduction, which is Rinne pause. So air conduction better than bone conduction. Okay. So air conduction better than bone conduction is Rinne positive. Make small corrections. Okay. So air conduction better than bone conduction is Rinne positive. So bone conduction better than air conduction is Rinne negative. It is seen in conductive hearing loss. It is seen in conductive hearing loss. Next is Weber's test. You strike the tuning fork, place it over the forehead. You ask the patient which side the sound is getting lateralized. If it is lateralized to the better ear, it is sensory neural hearing loss. If it is lateralized to the upper ear, it is called conductive hearing loss. Very, very, very important. The most sensitive test. Even 3 to 5 decibel loss can be detected. Okay. Most sensitive tuning fork test is Weber's test. Lateralized to the better ear na sensory neural hearing loss. Lateralized to upper ear na conductive hearing loss. Next test is absolute bone conduction test. So you keep it over the master process of the patient. You ask the patient, you raise your hands once you stop hearing. The patient will raise the hand. You also close the tragus and place it over the examiner. So if this happens, the patient will say that if we still hear the sound even if the patient stops hearing, which is that the patient's hearing is affected than the examiner. So reduced than the examiner, it is sensory neural hearing loss. So Weber's test can be done for both conductive loss and sensory loss. Okay, ABC is only for sensory loss. RNA is mainly for conductive loss. Okay. The most important diagnostic test is audiogram. So please listen to this thumb rule. If you apply this thumb rule, you will never ever go wrong. Please kindly listen to this. Okay. First, audiogram. What is audiogram? This is the audiogram. So the plotting of the decibel with the frequency is called audiogram. The plotting will be from above to below. Above will be 0 and below will be 10, 20, 30. 10 plus they will add. Okay. So how to find any curve in an audiogram? So first, any curve which is more than 25 decibel, now there is hearing loss present. Point number 1. Okay. The point number 2, if bone conduction curve is more than 25 decibel, it is sensory neural hearing loss present. Okay. The point number 3 is if there is air bone gap present, it is more than 10 decibel, it is conductive loss. If it is less than 10 decibel, it is sensory neural hearing loss. It is sensory neural hearing loss. Alright. So I'll tell again. First, we should find out whether the patient is having hearing loss or not. Point number 1. Then, with the help of the broken bone conduction lines, we should find out whether the patient is having sensory loss or not. Then, using the air bone gap, either we should confirm the sensory loss or we should confirm the conductive loss. So these are the protocols for diagnosing a disease from the audiogram. Diagnosing a disease from audiogram. So how to read an audiogram? What are the symbols in audiogram? Let's see. So 0x now, air conduction. 0 is for right side air conduction, x is for left side air conduction. Less than or more than symbol abhinna bone conduction. So red color line is for right side, R for red for right. So blue color lines are for left side. With that note, let me show you some of the images. So this side is a. So first, just look into this picture. It starts from above to below, 0 to below. Okay. So this is the 25 decibel mark. So any curve more than 25 decibel, thumb rule number 1 is hearing loss is present. So thumb rule number 1 is satisfied. The broken bone conduction line. So the broken lines are bone conduction. This is a right-sided audiogram, red color. So the broken lines for bone conduction. So continuous lines for air conductions. Continuous lines for air conduction. Now you look at this picture. The broken lines bone conduction is less than 25 decibel. So no sensory neural hearing loss. The third one, airborne gap is more than 10 decibel. Can you see here? This is 15, this is 40. The airborne gap is more than 10 decibel, which means that conductive hearing loss is confirmed. So this is a case of right-sided conductive hearing loss. Understood? Any doubt in that? If you have any doubt, you can ask for. So 3 thumb rules. Thumb rule number 1, any curve. Thumb rule number 2, sensory neural hearing loss, broken lines, less than 20 decibel, no sensory loss, more than 20 decibel, sensory loss is present. Third one, airborne gap. If it is less than 10 decibel, it is sensory loss, more than 10 decibel, it is conductive hearing loss. confirmed. See this picture. Any curve more than 25 decibel? Yes. Bone conduction more than 25 decibel? Yes. So SNHL is present. The third line. See the airborne gap is only 5 decibel. The airborne gap is less than 10 decibel. It is confirmatory of sensory neural hearing loss. SNHL means sensory neural hearing loss. SNHL means sensory neural hearing loss. Now this is the important thing. See here, the patient is having right-sided hearing loss. Thumbnail number 1 is more than 25 decibel present, yes. Thumbnail number 2 is bone conduction also more than 25 decibel, yes. SNHL is present. But thumbnail number 3, airborne gap is more than 10 decibel. Which means that conductive loss is present. So the patient will be having both conductive loss and sensory neural hearing loss. It is mixed hearing loss. Very, very, very important. Kindly, please don't mistake in this. That's why I have applied 3 thumb rules. If we apply only airborne gap, we may go wrong. Okay. So you should apply these 3 thumb rules. Thumb rule number 1, thumb rule number 2 is bone conduction. SNHL is positive. Thumb rule number 3, airborne gap is not less than 10 decibel. It is more than 10 decibel. It is mixed loss. The patient is having a perforation as well as nerve pathology. So what are the other patterns? How they may ask questions. The Carrat's notch is at 2000 Hertz bone conduction dip. Very important. Seen in otosclerosis. 2000 Hertz bone conduction dip is seen in otosclerosis. 4000 Hertz both bone conduction and air conduction dip is seen in noise-induced hearing loss. So rising SNHL curve. So is a sensory hearing loss, which is satisfying the 3 thumb rules which I just told you. So, but it is not uniformly seen. It will be seen in this way. So it's a rising SNHL curve is seen in Meniere's disease. Sloping SNHL curve is seen in test by acoustics or otherwise called as age-related hearing loss. Cookie bite pattern of SNHL is seen in congenital deafness. In congenital deafness. Let me solve this MCQs. So 30-year-old female doesn't follow following audiogram. See here, 2000 Hertz bone conduction dip. The audiogram is given. So if it is given in the 4000 Hertz, you may think of noise-induced hearing loss, but it's clearly case of Carrat's notch in otosclerosis. Very, very important. Last FMG they asked question. So 50-year male with tinnitus, vertigo, and fluctuating hearing loss. I have told you TVS. Tinnitus, vertigo, sensory loss. TVS. So I have told you what the audiogram is given. This is what audiogram. This is a rising curve. This is a rising curve. It is a case of Meniere's disease. Very easy to answer. It's a case of Meniere's disease. So which of the following conditions will cause bone conduction in fluid tone audiometry? Will cause bone conduction fluid tone audiometry. So in fluid tone audiometry, bone conduction will be better. So we see here, foot plate fixation, tympanic membrane perforation, ESC pathology, all will affect only air conduction. The inner ear pathology only affects bone conduction. It's nothing but cochlear pathology. Very easy question. Okay. So next is about BERA. Okay. So BERA we are yet to read. Okay. We'll answer once we read that. Next is approach to ear discharge. So I'll solve questions. I'll discuss the topics based on the approach, symptomatic approach to ear discharge, approach to hard of hearing, approach to vertigo, approach to ear pain. So we'll start with approach to ear discharge. If the patient is having a middle ear fluid without any infection. So I call it as, I compare this infection, middle ear infection always with a robbery. So a house is full of wealth. It is protected by a group of dogs. One fine day, the thieves are entering the house premises through the underground sewage tank. So if there is a fight between the dogs and the thieves, if the dogs wins, it is called acute otitis media. If the thieves wins, it is called chronic otitis media. The infection can go on and on. So without any infection, if the dogs are simply brought in, it is serious otitis media. Let me tell again. So in the house full of wealth, the thieves are planned for robbery. So when they are entering through the underground manhole or sewage pit, there will be a fight between dogs and the thieves. The dogs wins. The thieves will run away. It is acute otitis media. If the dogs are killed and the thieves enter into the house, it is called chronic otitis media. So what is this serious otitis media, sir? Serious otitis media is nothing but the dogs will be barking without any thieves. See here, there will be air fluid levels behind the intact TM. Okay, so this is called serious otitis media or secretory otitis media or otitis media with effusion. Serous, secretory, and otitis media with effusion. Okay. So what will be the impedance audiometry findings of this particular disease? See here, if it is an early disease, there will be only eustachian tube dysfunction, type C curve. But the most important one is this one. Please don't confuse this. What is the impedance audiometry in serious otitis media? Type B flat curve. Okay, type B flat curve. Okay, so late serious otitis media is a type B flat curve. So what is the treatment for serious otitis media? So what are the causes for serious otitis media? See here, it's very easy. So this is the middle ear. This is the nasopharynx. There is a connection between middle ear and nasopharynx. This is called eustachian tube. If the nasopharyngeal end of the eustachian tube gets blocked like this, this will result in the fluid accumulation in the middle ear. Okay. The reason is eustachian tube blockage. So what will cause eustachian tube blockage? What is the reason for serious otitis media? The reasons are in children, adenoid hypertrophy. Okay. In adults, carcinoma nasopharynx. Adults, it is carcinoma nasopharynx. Right. So the treatment of this is adenoidectomy with grommet insertion. Okay. So what is acute otitis media? The dogs are barking and the thieves escape. Having 5 stages: stage of congestion, stage of pre-suppuration, stage of suppuration, stage of restoration, stage of complication. So each will be having important signs. The most important sign is at the initial stage there will be cartwheel sign. In stage of congestion there will be cartwheel sign. In stage of suppuration there will be lighthouse sign. There will be a temporary perforation happening in the tympanic membrane. There will be intermittent release of discharge happening from the middle ear. It is called lighthouse sign pause. Those are the dogs were killed by the thieves, and the thieves have entered in the house to do robbery. It is called chronic otitis media. Okay, all the doors were broken permanently. All the doors were broken permanently. So mucopurulent discharge and permanent perforation of the tympanic membrane is called as chronic otitis media. Okay, sir. What are the types of chronic otitis media? So previously it was called as safe type or tubotympanic type. Nowadays it is called as mucosal type. So we are having a perforation over the tympanic membrane with discharge. It is an active disease. We have a perforation but no discharge. It is inactive disease. Okay. So there may be few conditions where there will be healed perforation. It is called as adhesive or it is clear. Let's get back to unsafe CSOM. Unsafe CSOM or attico-antral disease. Unsafe CSOM and attico-antral disease. In unsafe CSOM, whether you will be having active foul smelling discharge, okay? So foul smelling discharge plus blood bleeding will be there. Okay. Foul smelling discharge and bleeding will be there. So this is a active disease. No foul smelling discharge, only retraction packet is present. Now it is inactive disease. Very, 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 very important classification. Okay. So what is the mainstay treatment of blue ear 2018 FMG? It is myringotomy with aeration to the middle ear. So they have not given the option of atenodectomy with glomerular incision. Rather, they have given an option of myringotomy with aeration. So myringotomy is putting a hole on the tympanic membrane is called myringotomy. So with that will create aeration to the middle ear. Okay, myringotomy with aeration to the middle ear. So what will be the features of the CSOM? Ear discharge, hard of hearing, ear pain are the three cardinal features of the CSOM. So chronic negative pressure of the middle ear can lead to a retraction packet and then finally cholesteatoma. So what is called cholesteatoma? I have divided into two types. The first one is safe type, only perforation. Unsafe type, you may see cholesteatoma in few cases. So what is the bad thing about cholesteatoma? The cholesteatoma not only creates it's a product of retraction packet, but it will also cause bone erosion, ossicle erosion that will cause foul smelling discharge and bleeding. So what is the reason for cholesteatoma causing bone erosion? The cholesteatoma causes bone erosion by inflammatory osteitis, bone destroying enzymes and pressure compression. Inflammatory osteitis, bone destroying enzymes. You just make a note of this theories. So JIPMER theory is the most common accepted theory for cholesteatoma, retraction packet theory. Haberman's theory is a migration of epithelium through perforation. Sadie's theory, S for S, Thomas metaplasia theory. Rudy's theory is a basal cell hyperplasia theory. Rudy's theory is a basal cell hyperplasia theory. Okay. So we are having few types of tympanoplasties and we'll sort it out one by one. The first one is a myringoplasty. Tympanic membrane alone gone. We are reconstructing the tympanic membrane alone. Okay. It's the tympanic membrane. This is the malleus. This is the incus. This is the stapes suprastructure. Stapes foot plate. This is the round window. This is the oval window. So if only tympanic membrane eroded, we are reconstructing tympanic membrane is called myringoplasty, type 1 tympanoplasty. If malleus is eroded, we will place the graft over incus. Okay, place the graft over incus. Then malleus incus eroded, we will place the graft over the stapes suprastructure. It is called myringostapedioplex. If malleus, incus, and stapes suprastructure all are gone, only stapes foot plate is remaining. We will do round window shielding effect. So in otosclerosis, we will do type 5 tympanoplasty called fenestration procedure. Sound travel from round window to oval window instead of oval window to round window is called as sono inversion. The 5 and 6 are very rarely done. 6 is a hypothetical concept. Okay. So when we do surgery for a CSOM, we will do a surgery called cortical mastectomy. We should put incision over the ear. The first incision is Rosen's endometrial incision. The second incision is Lempert endoral incision. The third incision is the modified William incision, post-auricular incision. Okay, it's the most commonly used incision. It's called post-auricular incision. Okay. So McEwen's triangle. So when I'm doing a surgery for a patient, cortical mastectomy for a patient, I should be able to identify an important air cell called mastoid antrum. Okay. While identifying mastoid antrum, I should have the landmarks which is mentioned over here. So one is the superior line or supramastoid crest line. Then a line along the external auditory canal, the posterior wall of the external auditory canal. Then a tangent joining these two lines. So three lines. One is supramastoid crest line. One is posterior canal wall line. The third one is an imaginary line joining these two lines. So this is a triangle. If you do bone drilling along this triangle, you will reach the mastoid antrum. That will give you adequate ventilation. So that is very important. McEwen's triangle. So canal wall up mastectomy and canal wall down mastectomy are two types of mastectomy. Okay. So canal wall up mastectomy, the aim is disease clearance. It is done in safe type of CSOM. Hearing reconstruction can be done in the base of tympanoplasty. So otherwise called SWAT surgery, it is cortical mastectomy. So if we preserve the posterior canal wall, so you look at this canal wall, if we preserve the posterior canal wall, it is called canal wall up mastectomy. If you don't preserve the posterior canal wall, it is called canal wall down mastectomy. Okay, this is done in modified radical mastectomy. So if you do disease clearance alone, it is modified radical mastectomy. We are sacrificing the posterior canal wall. If we do disease clearance together with hearing reconstruction, it is called as canal wall up mastectomy or cortical mastoidectomy. All right. Been some 50 minutes since the class started. Okay. So another 2 hours of discussion is there. So I need a small break. Okay. So don't go anywhere. I'll come back. Small break. Okay. We'll come back for the next session. We have completed till the surgeries for the CSM. Okay. So now we'll discuss about complications of otitis media. So it's very important. So they may ask any of this complication as an MCQ. So first we'll have intracranial complication or extracranial intratemporal complication. So the CSOM can travel into the temporal bone alone, or the CSOM can enter into the cranial cavity also. If it enters into the temporal bone alone, it will cause a few complications. If it enters into the cranial cavity, it will cause different set of complications. If it enters into the cranial cavity, what are the complications? So first one is temporal lobe abscess, very important. This temporal lobe abscess, the patient will experience headache, normal aphasia, homonymous hemianopia, seizures. Out of which normal aphasia is very, very, very important. Yeah. The next one is meningitis. The patient will have headache, high-grade fever, projectile vomiting, necrosis. This all you know very well. Meningitis you would have read in medicine also. So the thing is, it can also lead to pus formation, some space occupying lesion in the brain, causing otitic hydrocephalus. So hydrocephalus increased intracranial pressure due to space occupying lesion. So what could be the space occupying lesion? It could be a cerebellar abscess, it could be an extradural abscess, it could be a subdural abscess. If it is cerebellar abscess, the important point you should note down is if the infection breaches a triangle called Trotman's triangle, it will cause cerebellar abscess. If it breaches the Trotman's triangle, it will cause cerebellar abscess. Very easy. The most important complication is lateral sinus thrombophlebitis or sigmoid sinus thrombosis. There will be bone erosion that will cause thrombus inside sigmoid sinus, that will cause obliteration. And the patient will have picket fence fever, and the patient will have Greisinger sign positive. Okay, and there will be few tests done to find out the pressure increase happening in the jugular vein. The test done for finding out the pressure increment in the jugular vein is Tobey-Eye test and Probeck test. Very, very important. They may ask this question: Tobey-Eye test and Probeck test. And if you take a contrast enhanced CT, you will see an empty delta sign. Contrast enhanced CT, you will see empty delta sign. All right. So we have done about intracranial complication. What are the intratemporal complication? First one is mastoiditis. See here, this is the tympanic membrane which is intact. This is the middle ear. This is the posterior part of the middle ear, which is the mastoid axonal system. So if there is pus formation into this mastoid axonal system with intact TM, there will be too much pressure. The pus will decalcify the bone over here. This is called hyperemic decalcification. The word is very, very important. Mastoiditis happens due to production of pus under tension due to intact TM, but mastoid having infection, hyperemic decalcification. Okay. What are the clinical features of mastoiditis? Fever, pulsatile ear discharge, we call it as reservoir and mastoid tenderness, and the mastoid swelling. Usually there will be a folding present over the posterior canal wall, but here there is no wrinkle is present. It looks like an ironed out feel over the mastoid. Looks like an ironed out feel over the mastoid. If there is tympanic membrane perforation, the patient will have conductive hearing loss. The patient will have conductive hearing loss. Important aftermath of mastoiditis. If the pus from the mastoid axis system can spread into a basalt, sternocleidomastoid is called basalt abscess. So basalt abscess means pus over sternocleidomastoid. Sitley abscess means pus over digastric muscle. Lux abscess means pus over external canal. Zygomatic abscess means pus over zygomatic bone. Okay. So we are done about mastoiditis, which is an intratemporal complication. Second one is labyrinthitis. We are having two types of labyrinthitis. One is circumscribed, second one is diffuse. If it is circumscribed, very little surface area, Histner test will be positive. If it is diffuse, there will be entire erosion or destroying happening in the labyrinth happening as a whole. If the labyrinth is having only serous discharge which is destroying, it will cause same side nystagmus. If it is a suppurative or pus pointing over the labyrinth, it will destroy the labyrinth, causing opposite nystagmus. If it is serous labyrinthitis, same side nystagmus. If it's a suppurative labyrinthitis, it is a contralateral nystagmus. It is a contralateral nystagmus. Okay. So the third important intratemporal complication, petrositis, or otherwise we call it as Grady-Nigo syndrome. Petrositis or Grady-Nigo syndrome. So the patient will have infection spread from the mastoid axonal system or the middle ear into the petrous part of the temporal. We have four parts of temporal bone: petrous part, mastoid part, squamous part, tympanic part. Squamous part is not important. So tympanic part is middle ear part, mastoid part is the mastoid axonal system part, petrous part is inner ear part. If the petrous part of the temporal bone getting affected, it is called Grady-Nigo syndrome. It has three cardinal features. Remember it as 3D: deep discharge, deep-seated eye pain, diplopia. This eye pain is due to fifth nerve involvement. This diplopia is due to sixth nerve involvement. The eye pain, fifth nerve involvement, diplopia, sixth nerve involvement. Right? So the question: a boy presented with history of ear discharge, ear pain, hearing loss, redness was present behind the ear, reservoir is positive. It is a clear-cut case of mastoiditis. So a patient presented to the OPD after being slapped, reduced hearing and ear blocking sensation. What is the next step of management? See, he is having reduced hearing. Okay. So after being slapped, the patient would have got traumatic perforation. So if the patient has traumatic perforation, you should just give antibiotics and follow up the patient. You ask the patient not to do head bath for at least 2 months, so that the perforation will heal on its own. If the patient do head bath, the perforation may not heal on its own. Okay. Tobii test is done for lateral sinus thrombosis. Dip at 4000 Hz frequency in audiometry indicates noise-induced hearing loss. So these are the questions asked from previous FMG. So otosclerosis, I have told you, external middle ear developed from separate embryology, which is pharyngeal arches. Inner developed from neural ectoderm. So the meeting point for these two different sources of embryology is foot plate of stapes. Okay. So at the foot plate of stapes, there is a, so embryologically it is different from other ossicles. The ossicle malleus in the stapes suprastructure forms from first and second as mesenchyme, but this foot plate of stapes is having embryology similar to the inner area, which is neural ectoderm, which is OT capsule. Fistula antifenestra. So this is the most common site for otosclerosis. What is the presenting feature? It occurs in females around pregnancy, around 30 to 35 years. Okay. So what will be the feature? The patient will be having bilateral conductive hearing loss. The patient will be having tinnitus. The most important named sign is paraacousis will reside. The patient will hear better in a noisy environment. What will be the sign? The patient will have Schwartz sign, which have flamingo pink appearance of the tympanic membrane. So Schwartz sign. So audiogram I have shown you already. Karatz notch at 2000 Hz bony dip. Impedance audiometry, AAS type of curve. That's also very important. So we have completed few of the diseases. Now we can enter into important objective diagnosis of the very, very, very important. Let me introduce you to two new words: recruitment phenomenon and rollover phenomenon. See here, for example, I'm not hearing, this ear is not hearing. Suddenly, if it hears more than normal, it is called as recruitment phenomenon. This ear is normal, one ear is normal, right ear is abnormal, right ear 10 decibel, 20 decibel, 30 decibel, 40 decibel, 50 decibel, nothing is heard. Suddenly 60 decibel is here more than normal. So sudden abnormal growth of loudness is called as recruitment phenomenon. It is seen in cochlear deafness. If there is some pathology over the cochlea, like Meniere's disease, age-related hearing loss, presbyacousis. Okay, this is called recruitment phenomenon. Now, there will be sudden rollover of higher intensity sound in speech audiometry. It is called rollover phenomenon. Okay, so in a retrocochlear deafness of vestibular schwannoma, okay, vestibular schwannoma. So there will be sudden fall in the higher frequency sound. It is called rollover phenomenon. So let us see what is speech audiometry. Speech audiometry, there are two types. One is speech reception threshold. Second one is speech distribution score. The important thing you need to understand is speech reception threshold. 50% of the words, if the patient is able to repeat, those words are bisyllable spondy words. It is speech reception threshold positive. But speech discrimination score, the patient should be able to repeat at least 90% of the words. It is called phonetically balanced words, and 90% of the words, if the patient is able to repeat now, we call it as PB max. Speech reception threshold, 50% of words. Speech discrimination score, it is PB max, which is phonetically balanced score, 90%. Very, very, very important. I have told you rollover phenomenon is seen only speech audiometry. Its use is retrocochlear deafness. Okay. Now we have seen about recruitment phenomenon. We have seen two diseases in recruitment phenomenon, which is Meniere's disease, age-related hearing loss. So Meniere's disease, what is the clinical presentation? Very easy. TVS, tinnitus, vertigo, fluctuating sensory neural hearing loss. If there is reversal of symptoms, we call it by the name Lermois syndrome. This Meniere's disease, It's very simple. If I am having a semicircular canal, vestibule, cochlea, this entire inner ear is filled with water. It is called venous tissue. It is called venous endolymphatic hydrops. Endolymphatic hydrops. The entire inner ear is getting filled with water. That water or fluid will compress the structures in the inner ear. That compression will create a lot of nuisance. That nuisance is cochlea getting affected, tinnitus, sensitivity loss. If the vestibule and the semicircular canal getting affected, it is called vertigo. Okay, so tinnitus, vertigo, fluctuating sensory loss. This means that this is a gold bag of MCQs. A lot of signs will be there. So false positive vestibular test, any bird sign. Sound induced vertigo, Tullio phenomenon. Hearing the same sound in two different frequencies, display accuses. Patient can hear the sound as more loud sounds, recruitment phenomenon. These are the signs seen in venous disease. Investigation, I've taken audiogram. I already told you, low frequency rising curve pattern. SNHL, but it's a low frequency rising curve pattern. What is the other thing? Glycerol test positive. Glycerol test positive. Okay. In electrocoagulography, SP by summating potential by action potential ratio will be more than 30%. Summating potential by action potential is more than 30%. Treatment for Meniere's disease. Meniere device, chemical labyrinthectomy, and we could do a endolymphatic sac decompression surgery. And surgery for intractable vertigo, it is labyrinthectomy. Labyrinthectomy. Okay. So what are the other acute diagnoses of the ear? So we have left out a few. BERA, OAE, impedance audiometry, very important. These three, they may ask a lot of MCQs. So these three, we are not relying on the response from the patient. Subjective diagnosis means if you do an audiogram, you ask the patient, if you hear the sound, raise the hands. Tuning fork test, if you hear the vibration, raise the hands. So the patient, if he tells lies now, the test may go wrong. But in objective diagnosis of ear, the test can never go wrong. Okay? Why the test can never go wrong? Because we are relying on some electrical measurements using some electrodes. So OAE, we are measuring the energy released from outer hashes. I have told you already the difference between inner hashes and outer hashes. The outer hashes release energy that will be sorted out by autoacoustic emission. Two types of OAE, spontaneous and emitted. So this OAE is useful in neonatal screening, ototoxicity, and auditory processing disorder. Very important. So BERA. So we are placing electrodes all over the skull of the baby, and we are measuring the electrical activity from all parts of the auditory pathway. So auditory pathway EECOLIMA is BERA. So the first wave is for eighth nerve. Second is for eighth nerve. The third is for cochlear nucleus. The fourth is for olivary complex. The fifth is for lateral lemniscus. The sixth and seventh is for mediate geniculate body, and in some cases auditory cortex. So what is this? This is the auditory pathway which we saw while discussing about physiology of ear. So AEE co inferior colleagues are left out. Sixth is for inferior colliculus. So nothing but EECOLIMA. So this is E for wave 1, wave 2, cochlear nucleus for wave 3, Audio calculus for wave 4, lateral limit space wave 5, inflow calculus wave 6. This is for wave 7. Okay. So this is BERA, electrical recording of various parts in the auditory pathway. What is the use of BERA? So BERA is used for gold standard for diagnosing congenital hearing loss. It's the most reliable test. Differentiate cochlear and retrocochlear deafness. Differentiate cochlear and retrocochlear deafness. Okay. So BERA, brainstem evoked response audiometry is very, very important. Okay. So what is impedance audiometry? So I am going to just measure the compliance and pressure of the middle ear. Measure compliance and pressure of middle ear. It is impedance audiometry. In impedance audiometry, I will get findings such as A curve is normal, which is zero pressure and normal compliance. If the compliance is increased, there is too much air inside the middle ear. It is auricular discontinuity. Okay. AD curve is auricular discontinuity. D for discontinuity. Then AS curve, compliance is decreased, pressure is normal, otosclerosis. If there is an E station dysfunction and E station gets closed, middle ear has negative pressure, it is type C. Negative pressure leads to fluid accumulation inside the middle ear. So I have already told you it's a serous otitis media. It is serous otitis media. So very, very important test, OAE, BERA and impedance audiometry, they may ask this. Then approach to hard of hearing. So we have completed approach to ear discharge, surgeries for that, test for that, everything I have shown you. Now approach to hard of hearing. The patient is coming to you with hard of hearing loss. So what do you do? So two approaches. If the tympanic membrane is in this case, I'm going to just show you the cases which is having intact tympanic membrane. First thing, intact tympanic membrane and conductive hearing loss on audiometry. So intact tympanic membrane and conductive hearing loss on audiometry, which means that this is not CSOM. Okay, if it's not CSOM, you should think of other causes such as external ear disease such as pinna, which is showing microtia or anotia. External technology showing stenosis or atresia. So external ear problem is not allowing the sound to get into the ear. It is one cause for conductive hearing loss with intact tympanic membrane. The second cause, the tympanic membrane is intact. We could see a white polymass behind intact EM. Okay, which means that it is congenital polycytoma. White polymass behind intact EM, it is congenital polycytoma. You could confirm it CT temporal bone. Or it could be otosclerosis where there is conductive bilateral conductive hearing loss in females. So it is Carrat's notch and ASO positive. Treatment for otosclerosis, you could give a sodium fluoride as medical treatment or surgically stepidotomy. Okay, surgically stepidotomy. Now let me show you the causes where there will be sensory neural hearing loss on audiogram. So which are the conditions where you will see sensory neural hearing loss on audiogram? See here, the patient may got some syndromic anomalies. I have told you apart from the Treacher-Collin and Goldenhar syndrome, lot of syndromes like Alport syndrome, Lawrence-Moon-Burke syndrome. So a lot of syndromes are there. Can be a syndromic anomalies or torch infection. Could be infection due to cytomegalovirus, toxoplasma. So any of the torch infection can cause a hearing loss. Or if it's a low frequency SNHL with rising curve, which episodic tinnitus, vertigo, and sensory hearing loss confirmed with electrocochleography, it is Meniere's disease. So intact TM, sensor loss, it is not a congenital deafness. If it is an acquired deafness, it could be a Meniere's disease. Or age-related hearing loss. Again, the group of phenomenon will be there, but it's a high frequency hearing loss. Low frequency hearing loss, Meniere's disease. High frequency hearing loss, age-related hearing loss, or otherwise called as presbycusis. Okay, fine. So in this, you should give a hearing aid for the patient. Should give hearing aid for the patient. The last thing, if there is a constant noise exposure and you will see a notch on audiogram at 4000 Hertz, it is noise-induced hearing loss. It is noise-induced hearing loss. Okay. So yes, sir, I got a hearing loss. It is either conductive hearing loss or sensory hearing loss. How can I treat the patient? So in this patient, most of the patient we can't give any surgical advice because nerve is lost. I am telling about sensor loss. Sensor loss, nerve is lost. We can't do surgeries in inner ear and all. So what shall we do? We could give some amplification device such as hearing aid or middle ear implant or cochlear implant or brainstem implant. So hearing aid is nothing but you would have seen this here. Conventional hearing aid where intact ear canal is there. So canal is intact. We are having canal ear plug. So behind there will be amplifier, processor and receiver. RAM. Receiver, amplifier, processor. Microphone. Canal atresia or CSOM like that. If there is ear canal is affected by that is not formed properly or if it is filled with infection, you could prescribe a hearing aid device called BAHA. Very important. They may ask this question. Bone anchored hearing aid. BAHA is a bone anchored hearing aid. See, I'm behind the ear. I'm introducing this BAHA. This BAHA is placed into the mastoid bone with the help of a titanium abutment. So this can be tried. No, latest devices. I'm doing a surgery. I'm implanting the aid into the middle ear ossicles. So middle ear implant can amplify the hearing. This is also a method. Next one, I'm having severe hearing loss. Okay, so I should give a cochlear implant or brainstem implant. If I'm introducing through the round window into the scala tympani, it is cochlear implant. If it is placed over the lateral recess of fourth ventricle at the brainstem, it is called brainstem implant. You could do anything. So if inner ear is normal, you could do a cochlear implant. If inner ear is also abnormal, you could do only a brainstem implant. Okay. So scala tympani through the round window. Very, very, very important. Cochlear implant. The brainstem implant, lateral recess of fourth ventricle. All right. So finished approach to ear discharge, approach to hard of hearing. Now we'll study about approach to ear pain. The patient is having, first what are the nerve supply of pinna? Pinna is having greater auricular nerve, lesser occipital nerve, ulnar branch of vagus. Okay. And also auriculotemporal nerve. Which is a branch of mandibular division of trigeminal nerve. External auditory canal. The external tree canal is anterosuperiorly supplied by auriculotemporal. Now, posteriorly supplied by ulnar branch of vagus. Okay. The middle ear is supplied by Jacobson branch of glossopharyngeal. It will form tympanic plexus. Okay. With this nerve supply, we can solve some MCQs from the 2023 FG. 50-year male, swelling below the ears and pain over the lobule, was not able to close his eyes completely. He is also having difficulty in eating food. Which of the following nerve is most likely damaged? Swelling below the ears, pain over the lobule of the ear, unable to close his eyes completely. So this is facial nerve palsy. Okay, this is facial nerve palsy. So what are the external ear causes of ear pain? First is perichondritis. So the concept is very simple. The perichondrium has feeble blood supply. If it is traumatized or if it is cut down, that can lead to a lot of infection in the form of perichondritis. So you should give high-grade antibiotics and do an instant drainage if it forms some pus points. Okay. Second one, if there is no infection, only blood is filling the pinna. Only blood is filling the pinna. It is called hematoma of pinna, or otherwise called boxer's ear, cauliflower's ear. They may ask this as a picture-based MCQ. Please make a note of it. So boxer's ear, cauliflower ear due to hematoma of pinna. Okay. I am having a severe ear pain with the ear canal edema. Okay. Diffuse otitis extra. It is otherwise called as telephonist ear or swimmer's ear. Here the patient will be having tragal sign positive. If you press the tragus, the patient will have tenderness. It is called tragal tenderness or tragal sign positive. Clear? So diffuse otitis section, otherwise called telephonist ear, swimmer's ear, very, very important, tragal sign positive. It is not diffuse, only located to some of the hair follicle or one of the hair follicle. It is furunculosis. Infection of the hair follicles mostly caused by Staph aureus is called as furunculosis. Very, very important. For both the diseases, you should give you antibiotics as treatment. If there is too much humidity or moisture inside the ear, it can lead to fungal growth. The most common fungus affecting the ear is Aspergillus niger will have black colonies, Candida will be having white colonies, Aspergillus fumigatus will be having yellow colonies. Okay, what will be the cause of this patient? The patient will be having due to tropical climate or prolonged use of antibiotics or prolonged usage of antibiotics. Appearance and presentation, the patient will be having edematous ear canal with severe ear pain. Edematous ear canal with severe ear pain. Okay. Treatment is you can give salicylic acid or antifungal such as clotrimazole or fluconazole. Antifungal such as clotrimazole or fluconazole. Okay. So some different disease, they may ask this as an MCQ. So if there is small amount of keratin happening in the ear, it is called wax. But there is a problem with the disposal of the wax from the ear, deficiency of a KADS, keratin attachment destroying substance. If there is this substance, which is supposed to shred off the wax from the ear, it is not present now, the keratin will get accumulated into the ear. Accumulation, chronic accumulation of the keratin is called as keratosis obturans. Okay. Chronic accumulation of keratin is called as keratosis obturans. Okay. Some chronic cases of keratosis obstructions can even erode the facial nerve. Okay. Some chronic cases of the keratosis obstructions can even erode the facial nerve. What are the treatment for keratosis obstructions? Keratinolytics and surgical removal. Okay. You look at this picture, they may ask us a picture based MCQ. Too much of wax formation, the patients can have even have facial palsy. That much of severity can happen now. It is keratosis obstructions. The most important disease, they may ask this a lot of times. Malignant otitis externa, immunocompromised patient with Pseudomonas infection. There is black granulation along the floor of the external canal. So that is called malignant otitis externa. Pseudomonas infection, type 2 diabetes, uncontrolled. That is with facial palsy. It is malignant otitis externa. So technician maintenance scan is a diagnostic scan. gallium 67 scan is prognosis scan. They may ask all these points are as MCQ, very important disease. So we have completed approach to ear pain. These are the external ear causes that will cause ear pain. Inner ear causes will not cause ear pain. Only the middle ear, some acute otitis media can cause ear pain. Other than that, mostly the external ear causes will be the culprit for ear pain pathology. The fourth important approach, we have completed approach to ear discharge, approach to hard of hearing, approach to ear pain. This one is approach to vertigo. So this one we know already. So macula is present at the atrial, horizontal linear acceleration, linear balance. Macula at the saccule is for vertical linear balance. It's a two-dimensional. Okay. The crystal amplet is for three-dimensional angular balance at a semicircular canal. So normally, if we have some abnormal head movement, there will be physiological vertigo and nystagmus happening in our body. So when can a pathological vertigo and nystagmus can happen? The first is positional changes. The disease is benign paroxysmal positional vertigo. Okay, or if there is an erosion of the lateral semicircular canal by cholesteatoma, or if there is a bony defect like superior semicircular canal dehiscence syndrome. Superior semicircular canal dehiscence syndrome. So these three are the features where even without any abnormal head movement, like we are riding in a roller coaster, without any such happening, the patient will have positional vertigo and nystagmus even at rest. So these are the diseases: BPPV, benign paroxysmal positional vertigo; cholesteatoma, causing erosion of lateral semicircular canal; superior semicircular dehiscence syndrome, which is a bony defect of the semicircular canal. Okay, what are the tests we can do? First, we could do a caloric test for intact tympanic membrane. Should not be done for perforated TM. For intact tympanic membrane. So, I'm going to instill water into my ear. If the water is cold, the direction of nystagmus will be opposite side. The water is warm, the direction of nystagmus will be the same side. COWS, cows. Okay. So cows means cold water, opposite side, warm water, same side. Cows. Okay. So it is nothing but caloric test or Fitzgerald-Halpike bithermal caloric test. Okay. Next one is positional test. In positional test, either you could do a diagnostic test in the form of Dix-Halpike or therapeutic test in the form of Epley's maneuver. Diagnostic test in the form of Dix-Halpike, therapeutic test in the form of Epley's maneuver. Very important. Okay. So fistula test. To find out whether there is fistula found by cholesteatoma or not, we should pump air with a pneumatic speculum like this. So this is pneumatic speculum. So if there is fistula test positive. Some diseases without any fistula can have some vertigo and nystagmus following this fistula test. Those diseases are called Henneberg sign positive. Diseases are very important. Meningitis disease, congenital syphilis, superior semicircular canal dehiscence syndrome. So it is Henneberg sign false positive fistula test. Sometimes there may be a fistula, but the patient will not respond to the fistula. Okay. So in that cases, so false negative fistula test in dead labyrinth. False negative fistula test in a dead labyrinth. Okay. Then we could do few tests for vestibular response. The test for vestibular ocular reflexes, saccades and pursuits, we will do a video and electronystagmography. Then for vestibular cerebellar response, we'll have Romberg's test positive, finger nose test positive, adiadochokinesia, and then ataxic gait. So these are the tests for vestibular response. Vestibulospinal pathway. So for vestibulospinal pathway, we could do a test called VEMP, vestibular evoked myogenic potential. Vestibular evoked myogenic potential. The two types of VEMP. One is ocular VEMP. The second one is cervical VEMP. The ocular VEMP is based on superior vestibular nerve involvement. The cervical VEMP is based on inferior vestibular nerve involvement. Okay. So and also you should know the difference between central nystagmus and peripheral nystagmus. Central nystagmus is a gradual onset. The nystagmus duration will be very longer. It's either purely vertical, purely horizontal, not mixed. Direction changing, associated with some CNS symptoms such as stroke or any brain pathology. No suppression with gaze fixation. non-fatigable. Okay, it's a non-fatigable. Okay, fine. Whereas in a peripheral nystagmus, it will be a sudden onset, last for only few seconds. Horizontal torsion nystagmus, it can occur only at the site of the lesion. It is associated with ear symptoms. Okay. So it is suppression with gaze fixation, and it is a fatigable. It is a fatigable nystagmus. Okay. The difference between central nystagmus and a peripheral nystagmus. We could do few tests for finding out whether it is central nystagmus or peripheral nystagmus. The most important bedside investigation is head impulse test, nystagmus, and test for skewness. Head impulse test, nystagmus, and test for skewness. The head impulse test, if it is positive, na peripheral nystagmus. Test for skewness is positive, na central nystagmus. That's the most important thing. Nystagmus based on direction, we could tell it is a central nystagmus or peripheral nystagmus. So that's all about HIMSS test. So we'll finish few of the tumors. Okay. So glomus tumor. Glomus tumor is the most common benign middle ear tumor. Most common benign middle ear tumor. This glomus tumor is given to two types. One is glomus jugulare, glomus tympanicum. The glomus jugulare arises from the jugular bulb, can spread even to the neck. So floor of the middle ear. Glomus tympanicum arises from the medial wall of the middle ear. It is limited to ear only. Okay. Both these types can spread into the middle ear mastoid cavity, but if it spreads earlier into the neck, it is glomus jugulare. If it is limited only to the ear and spread to the mastoid cavity alone, it is glomus tympanicum. Many signs are present in glomus tumor. Okay. So vascular mass arising from the floor of the middle ear, it is called rising sun sign. It's called rising sun sign. If there is blanching or of the retinas on applying pressure, it is called aquinose sign. The pulsatile swelling is called pulsation sign or brown sign. If the on CT scan, if you see erosion of the bony canal between the jugular vein and carotid artery, it is called as Phelps sign. It's called as Phelps sign positive. So rising sun sign, aquinose sign, brown sign, and Phelps sign. So treatment for glomus tumor is surgical excision. It's a surgical excision. Next tumor is most common benign inner ear tumor is vestibular schwannoma. So here the tumor arises from the Schwann cells of the vestibular nerve. The main features are progressive sensory hearing loss, tinnitus, vertigo, anesthesia over the posterior canal wall, which is called as Spitzel-Berger sign positive, and also cerebellar signs will be positive, which is involving cerebellum. Also very important tumor. This retrocochlear deafness, Rono phenomenon positive, and also histopathology. You will have antennae A, antennae B pattern. Very important. CT scan shows the acoustic neuroma here. So what is the treatment? As it is a benign tumor, if it is less than 1.5 centimeter, you do follow up for symptoms. 1.5 to 2.5 centimeter, you do a stereotactic radiosurgery irrespective of age. More than 2.5 centimeter is an open surgery. More than 2.5 centimeter is an open surgery. For more than 75 years, you should treat only if it is more than 2.5 centimeter and symptomatic. So more than 75 years, you should treat only if it is symptomatic. Okay, only if it is symptomatic. Yeah. So I'm having a lot of dehydration of late. So I need to take a break again. So this will be the last break. After this, I will finish the class, finish the session. Okay. So nose and throat will go on a rapid pace only. So it's nothing to discuss deep into nose and the throat. But ear is very important. That's why it took a lot of time. So I have another 5 minutes of break. I'm very dehydrating. Sorry for the delay. So 5 minutes break. I will take back and I will come back. Okay. 5 minutes. So welcome back to the session of the break. So we'll start with facial now. The facial of, so first we need to know about the facial course. Then we should know about the pathologies associated with the facial now. So the facial now is an important now. It's a mixed now, which is having both sensory and motor components. So first the intracranial course. The time is 10:50. We'll close the session sharply by 12. So the first intracranial course, see here, it arises from the pontomedullary junction. Arises from the pontomedullary junction. Then it enters the ear through the internal auditory meatus. Okay. Then the intratemporal course will be having 4 parts. The first one is intracanaliclar part, which is 5 to 8 millimeter in length. Then labyrinthine part, which is not covered by bone, so it is prone for injury, which is the narrowest, and is 3 to 5 millimeter in length. So after that part, we will be having tympanic part, which is otherwise called horizontal part of the facial now. There will be no branches from this part of facial now, 9 to 11 millimeter. Now you see from labyrinthine to the tympanic part, there will be a geniculate ganglion. From the geniculate ganglion, there will be greater superficial petrosal nerve that arises. Okay. From the geniculate ganglion, there will be greater superficial petrosal nerve that arises. So mastoid part or vertical part will be having nerve to stapedius and chorda tympani nerve. Okay. So I'll repeat it. Intracanaliclar part. Then labyrinthine part, which is more prone for injury. Narrowest part, but not of much branches. Okay. Geniculate ganglion will be seeing a greater superficial petrosal nerve. The tympanic part will be having 9 to 11 millimeter length, no branches. The mastoid part is again more important. Will be having nerve to stapedius and chorda tympani nerve. Okay. Nerve to stapedius supplies stapedial tendon that we have seen already. Chorda tympani tastes supply over the anterior 2/3 of the tongue. Extracranial branches out of the temporal bone, we'll see a lot of branches. First, it comes out of the stylomastoid foramen. The terminal branches are temporal, zygomatic, buccal, marginal, cervical. The mnemonic for this is 10 zebras bit my cat. 10 zebras bit my cat. Okay. 10 T for temporal, zygomatic, buccal, marginal mandibular, cervical. Clear? So what are the landmarks for the facial nerve? The facial nerve will have landmarks such as intratemporal landmarks and then near the extratemporal landmark near the parotid gland. Very important. They may ask this question. So intratemporal landmark. See here. If this is the medial wall of the middle ear, I've shown this picture already. So see, look into this. So this is the middle of the middle ear. Okay. In this middle of the middle ear, we'll be having oval window, round window. This one. So we have seen this. We have seen this now. So the facial nerve will be posterior superior to oval window or round window. Point number 1. The second one, it is superior to process cochleariformis. Okay. Here will be the process cochleariformis. Okay. Superior to process cochleariformis. Then it will be behind the pyramidal eminence. Okay. Behind the pyramidal eminence. Then it is inferior to lateral semicircular canal. It is inferior to lateral semicircular canal. Then it is medial to short process of ingress. Medial to short process of ingress. So very important points. See, it is superior to process of is not inferior. Then posterior superior. Then behind the pyramid. Okay. Now extra temporal parts. This is important while doing a parotid gland surgery. So tragus or condylis pointer 1.5 centimeter anterior and inferior to this point. 8 millimeter deep to tympanomassa suture line. Then lateral to steroid process. Then superior to posterior belly of digastric. Okay. So these are the extra temporal landmarks. So which of the following is used as landmark for facial and parotid gland surgery? Tragal pointer. Okay. Others are not correct. Okay. Steroid process they have not given specifically. So lateral process steroid process they would have given, or a posterior belly of digastric would have given, or tympanomassa suture they would have given. So that is not the case. Then the facial nerve when this comes into the internal auditory meatus, it forms relationship with other nerves at the internal auditory meatus called a Bill's valve. So superior vestibular nerve will be above, inferior vestibular nerve will be below. Seventh nerve, coke, 7 up and coke down. If you are sitting in a restaurant, you are ordering 7 up and coke bottle, you are keeping the 7 up above the table, you are keeping the coke bottle below the table. So 7 up the table, coke below the table. It's very, very, very important. The transition and the partition between these two is falciform or transverse crest. So here there will be a partition called Bill's valve. Okay. The facial palsy, supranuclear lever, bilateral innervated. So if it is a upper motor neuron facial palsy, only lower half of face is affected. Very, very important. UMN facial palsy, only lower half of face getting affected. Okay. Upper motor neuron facial palsy, lower half of the face alone affected. Okay. Whereas Bell's palsy, it is a lower motor neuron idiopathic facial palsy, completely one side is affected. So Bell's palsy is a lower motor neuron type of palsy. So in Bell's palsy, there will be loss of frowning, loss of nasolabial fold, incomplete closure of eyelids, deviation of angle of mouth like this. Okay. Cause, no cause or it's idiopathic. Treatment 1 milligram per kilogram steroids, no role for surgery. Bell's palsy, they ask this question, very, very important. Lower motor neuron idiopathic facial palsy. So which of the following drugs will be best to prescribe for facial palsy? It's obviously prednisone, which is a steroid. Okay. That will be a completed otology. You can enter into rhinology. So an infant developed difficulty in breathing with improved on crying. See, if the difficulty in breathing improve on crying, it is a typical case of choanal atresia. Okay. Let's see about the choanal atresia. The choanal atresia is nothing but a posterior end of the nasal cavity, which is having atretic segment of bone. So bucconasal membrane of Hochstetter is prominent. It is a part of charge syndrome. Okay. So difficulty in breathing is a presenting symptom which improves on crying. So the infants being obligate intranasal breathers, they will have no space for breathing through the nose. If that is the case, you could introduce a nipple into the mouth that is called McGowan nipple. A nipple into the mouth is called as McGowan's nipple. So if there is an atresia over the posterior part of the nasal cavity, that atresia is not improving, you could do a serial dilatation or excision of that atresia with flap cover. The serial dilatations or excisions with flap cover. So atresia, can you see this picture? This is the posterior end of the nasal cavity. It is completely atretic. Okay, fine. See here, it is completely atretic over here. This is McGowan's nipple. Okay, so treatment is serial dilatations or excision with flap cover. Other congenital lesions of root of the nose, the patient can have nasal derma, which is an external nasal tumor, simple cyst, do excision. Nasal encephalopathy, the patient is having contact with the brain parenchyma. The Furstenberg sign positive. What is Furstenberg sign? Whenever the child coughs, the swelling will increase in size. So increase in size on coughing, there will be increase in intracranial pressure, thus swelling on contact to the brain can increase in size. It is Furstenberg sign positive. If the Furstenberg sign is negative, it is nasal glioma. See, previously it had connection with the cranial cavity. Now the connection has been cut off. It is called nasal glioma. Furstenberg sign negative. Okay. The most important anatomy in entire ENT is anatomy of the middle ear. The middle ear is having osteometal complex. Okay, which is serving as the drainage point for sinuses such as maxillary sinus, frontal sinus, anterior ethmoidal sinus. Maxillary sinus, frontal sinus, anterior ethmoidal sinus. All these sinus opens into the anterior osteometal complex. Some of the important landmark in this middle meatus is hiatus semilunaris, infundibulum, and ethmoidal bulla. What is hiatus semilunaris is very easy to understand. See here, this is the septum, this is the nasal cavity, this is the middle turbinate, this is the inferior turbinate. So this is the area which we are talking about. Okay, in this area, if it is below the ethmoidal bulla air cell, it is called hiatus semilunaris. If it is between the uncinate bone and lateral wall, it is called infundibulum. And ethmoidal bulla or bulla ethmoidalis is the most constant ethmoidal axis. Bulla ethmoidalis, ethmoidal bulla, both are same only. So below ethmoidal bulla, hiatus semilunaris. Between uncinate and lateral wall, infundibulum. Most constant air cell, ethmoidal bulla. Now, almost all the sinuses will open into the middle meatus. So what else will open into the superior meatus? Posterior ethmoidal sinus will open into the superior meatus. Nasolacrimal duct will open into the inferior meatus. Very important. Okay. See here, bulla ethmoidalis drains into which among the following? It drains into middle meatus or osteometal complex. Okay. Sphenoethmoidal recess that we have not seen. Sphenoethmoidal recess, sphenoid sinus will drain. Sphenoid sinus drains into sphenoethmoidal recess. Okay. So, examination of nose, either we can do an anterior rhinoscopy using the speculum such as tunicum nasal speculum. We could visualize only till the middle turbinate internal nasal wall. So, posterior rhinoscopy, we are introducing a mirror through the oral cavity. So, posterior end we could visualize this with. So, Sinclair Thompson posterior nasal mirror. So, we could visualize posterior choana, turbinates and contents of the nasopharynx till the soft palate of pharynx. Okay. So, anterior rhinoscopy or posterior endoscopy was conventionally done. Nowadays, we are doing only diagnostic nasal endoscopy using our endoscopes. Okay. So, what is the blood supply of the nasal cavity? The blood supply of nasal cavity. So, you look at this question. A 42 years female present with bleeding from nose, the commonest artery could be. The commonest artery to cause bleeding in nose is sphenopalatine artery. Okay. What are the other arteries? Greater palatine artery and then superior labial artery. So, sphenopalatine artery, greater palatine artery, superior labial artery, these three are branches from external carotid artery. The anterior and posterior ethmoidal artery are branches from internal carotid artery. So, diseases of the paranasal sinuses, either it is acute sinusitis or chronic sinusitis. If the duration is less than 12 weeks, it is acute sinusitis. More than 12 weeks, chronic sinusitis. Acute sinusitis mainly due to viruses. Chronic sinusitis can be due to either bacteria or fungus. So what is the development of the parallel sinuses? MESF. You just remember MESF. Mnemonic. So maxillary develops first, then ethmoid, then frontal, then sphenoidal, then frontal. So this is the order of development of the paranasal sinuses. Okay, and also order of sinusitis is also same. So which sinus has more propensity for sinusitis is maxillary, then ethmoid, then sphenoidal, then frontal. Okay. Location of the pain. So based on the pain, a patient coming to you with nasal block, nasal discharge with facial pain. The pain is over the cheek, you think of maxillary sinusitis. The pain is over root of nose, you think of ethmoid sinusitis. The pain is over forehead, you think of frontal sinusitis. If the pain is over occiput, you think of sphenoid sinusitis. Here, few questions from this chapter. Most common site of obstruction by nasal polyp maxillary sinuses. So whatever question like this they may ask, the first answer you should give is middle meatus. Office headache is due to inflammation of which sinus? Frontal sinus. So pain over the forehead, it looks like an office headache. Okay. The most prominent and larger ethmoidal abscess is ethmoidal bulla or bulla ethmoidus. Both are same. Okay. Very important questions. So sinus is an inflammation of the paranasal sinuses. If the sinus inflammation is not settled with antibiotics, it can lead to a lot of complication. Extracranial complication, intracranial complication, extracranial complication, orbital complication is very important and most common. The orbit getting some orbital cellulitis, orbital abscess like that. Okay. So orbital complication is the most common. Other complication, frontal osteomyelitis. It will be Pott's Puffy tumor. Pott's Puffy tumor. What are the intracranial complications? It could be subdural empyema, meningitis, extradural abscess, and then cavernous sinus thrombosis. Okay, subdural empyema, meningitis, extradural abscess, cavernous sinus thrombosis. Okay. Now the most important part, fungal sinusitis. See, the normal sinusitis that we get after head bath, these are all bacterial sinusitis. This fungal sinusitis can happen in some diabetic patients and all. Okay. If it is a non-invasive fungal sinusitis, it could be a fungal ball or allergic fungal sinusitis. Fungal ball, it mostly happens in a voluminous sinus such as maxillary sinus and sphenoid sinus. What is this allergic fungal sinusitis? If there is too much spores present in the nasal cavity, there will be allergic reaction happening inside the nasal cavity. So that will cause allergic mucin. Okay, and then heterogeneous opacity on CT scan. Okay. So fungal sinusitis, invasive. It could be a chronic aspergillosis, but the most important invasive fungal sinusitis is mucormycosis. Mucormycosis, very, very, very important. It is an invasive fungal sinusitis. It can cause orbital invasion, palatal erosion, even cranial spread. During COVID, you would have seen a lot of mucormycosis patients, black fungus. So other fungus and all will not cause such rapid progress. This fungus, the day of causing the disease, can cause death of the patient in a matter of 2 or 3 days. Okay, in a matter of 2 or 3 days, it could cause even death of the patient. Okay, so that is acute invasive fungal sinusitis or mucormycosis. Okay. Surgical management of sinusitis is FIS. The patient can have uncinectomy, can have middle meatal antrostomy, ethmoidectomy, sphenoidectomy, and then frontal incision. This is the order for FIS. So for any nasal pathology, sinusitis, or any small tumors or any block, you could do a FIS. What is FIS? Functional endoscopic sinus surgery. What are the steps in FIS? The first step is uncinectomy. You're removing uncinate bone over the middle meatus. Then we are doing middle meatal antrostomy, opening the maxillary sinus opening. Then ethmoid opens. Then sphenoid open. Then frontal recess opened. Okay, frontal recess opened. So we have seen about complications of sinusitis. There are few complications of FES also that could happen. So complications of the FES. Intraoperative and perioperative, the patient can have orbital hemorrhage, CSF leak, and then optic nerve injury. These are the vital structures that is covering the nasal cavity. So optic nerve comes from the optic canal and reaches the posterior wall of the ethmoid sinus and enters into the orbit. So optic nerve can be injured. So roof will be having the cribriform plate of ethmoid, which is very tiny bone. That bone can get injured, cause CSF leak, or there may be a orbital hemorrhage happening in the patient. Okay, these are the intra and perioperative complications. There could be few long-term complications such as Seneca and frontoethmoidal mucosis. Seneca and frontoethmoidal mucosis. So here we'll see a question from 2023 paper. 54 years male presented with right-sided nasal obstruction for 6 months. On examination, there was an irregular mass present over the lateral wall of nose. The possible cause could be, see, there is a nasal obstruction, 6 months, irregular mass. So 54 years male, right side nasal obstruction, 6 months, irregular mass present lateral wall, possible cause could be. So ethmoidal polyp, antrochal polyp, rhinosporosis, rhinolytic. So 6 months, lateral wall of the nose, it could be a antroconal polyp. Unilateral means it could be a antroconal polyp. They have not commented anything about the bath in ponds. If the patient do bathing in ponds, it could be rhinosporosis. If there is history of foreign body nose, it is rhinolytic. Okay, so there is no history of bath in ponds and it's unilateral. One side nasal obstruction, no epistaxis. It could be antroconal polyp. Ethmoidal polyp will be bilateral due to allergy. Okay, so unilateral due to infection, it could be antroconal polyp. Few sinonasal tumors, two tumors very important that we could discuss. Carcinoma maxilla can be due to softwood exposure, nickel exposure, chromium exposure. All these are occupational hazards for the patient. So from the maxillary sinus, it can go above into the orbit, causing proptosis, into the nasal cavity, causing nasal obstruction epistaxis, into the palate, causing palatal erosion. So superiorly, orbit causing proptosis, medially causing nasal obstruction epistaxis, inferiorly palatal erosion. The staging for maxillary sinus, they have asked a lot of times. See here, Ongren's line, a line drawn from the medial canthus supply to the angle of mandible. If it is below this level, good prognosis. Above this level, bad prognosis. Then Lederman's classification is another classification where two horizontal lines or two vertical lines are used to stage the prognosis of the carcinoma maxilla. TNM staging is now the routinely used setup where it is best for prognosis and follow. So CA maxilla, it's a big tumor. Early lesion, you do surgery, good result. Late lesions, you do surgery with radiotherapy. Okay. CA maxilla, the exposure is very important, spread pattern is very important, surgery is the treatment, main treatment. Inverted papilloma, it's a very important tumor. It's also called as Schneiderlin papilloma, Ringer's tumor, transition cell tumor. Commonly in elderly male, site is lateral wall of the nose. The cause is human papilloma virus. It is called inverted because usually tumor goes from the surface above, but this one from the surface it goes below. Okay, it grows from the epithelium into the stroma. That's why it is called as inverted papilloma. Okay, now you look into this endoscopy picture. It looks like finger-like projection. It looks like finger-like projection. Done. The inverted papilloma patient presents with nasal obstruction and epistaxis. Nasal obstruction and epistaxis. Okay. Treatment, minimal disease and then extensive disease. Endoscopic medial maxectomy for minimal disease. Extensive disease, external approach is preferred. That will be too much scarring for the patient. Right? So the recurrence is more common. You should always watch for recurrence in the patient. Another small disease, If it arises from the olfactory epithelium, it is called olfactory neuroblastoma. The patient will experience anosmia, epistaxis, nasal obstruction. The problem is it can go below causing nasal cavity and go above completely occupying the cranial cavity. So it will cause nasal obstruction, epistaxis also, and also cranial split also. Very difficult tumor to treat. So previously it was called as neuroblastoma. Presentation I have told you. The histopathology they may ask this: small blue tumor cells with rosette formation. Treatment is endoscopic excision. Endoscopic excision. Atrophic rhinitis or otherwise called ozena. See, a bacteria getting invaded into the nose, unhygienic nose. It is growing over there. It is causing atrophy of the turbinates. Inferior turbinate, middle turbinate, everything getting atrophied. What is the causative bacteria? Klebsiella ozena. What is the reason for this? There could be a deficiency of vitamin D, deficiency of estrogen, and also the unhygienic getting colonized by infective bacteria. Presentation very important. There will be atrophy of the turbinates. Due to atrophy, there will be roomy nasal cavity, okay, and there will be greenish crusting, and there will be merciful anosmia. Merciful anosmia. Okay, the patient will have too much of foul-smelling greenish discharge, but the patient due to anosmia cannot feel the wound's bad smell. That is merciful anosmia. We should give nasal douching to remove all the crusting from the nose with either chemisetting anti-ozena solution with vitamin D, estradiol, and chloramphenicol. Or else you do surgery. You close one nose, it is Young's procedure. To close both the nose, a small gap between, it is modified Young's procedure. Very important treatment name. So Young's procedure, modified Young's procedure, they may ask this as a question. So which is done in atrophic rhinitis. Why it is done? Because only air entry will grow the bacteria. If there is no air, the bacteria will die. So if you close the nose, the air entry is affected, so the bacteria can die by itself. That is the best treatment of choice. So foreign body nose, very important. Unilateral foul-smelling epistaxis or discharge, you remove the foreign body as early as possible. Rhinolith, some 14-15 years child, they have left over foreign body, they have forgotten. If it grows and forms granulation tissue for a lot of time, even 4 or 5 years, it can cause a mass like this. It is called rhinolith. Forgotten foreign body undergoing chronic granulation is called as rhinolith. So chronic unhygienic nose due to some debilitating pathology. The patient is having stroke, unhygienic nose. Okay. So in that patients, the housefly will lay eggs. That housefly eggs will hatch to form the larva. That larva will become a worm. That worm is nasal myiasis. The housefly species name is Chrysomia. So unhygienic nose getting colonized by pulu. Okay, pulu inside the nose is nasal myiasis. How can you treat this patient? You give halothane and turpentine oil. Due to irritation, all the larva will come out. Unless otherwise, the patient will have some worse, serious aftermath. Okay, so if you don't treat adequately, the patient can have very worse symptoms. So next disease from nose, rhinosporidiosis. Rhinosporidiosis is caused by a protozoa called Rhinosporidium seaberi. Very important. If you are bathing in a pond water, the pond water will go cow dung. The cow dung will be having the spores of this particular protozoa. So Rhinosporidium seaberi spores entering into cow dung entering into pond, the pond entering into the nasal cavity while bathing. So that will cause the disease. What is the presentation? Reddish nasal mass which is studded with spores. There will be nasal obstruction and epistaxis. See, when we look into this picture, we could see small spores here and there. Okay, so that is the presentation of this rhinosporidiosis. Treatment very important. Dapsone can be given. So to halt the growth of the protozoa, you could give dapsone 50 milligram. And surgical treatment, you could surgically excise and cauterize the base of the patient. Rhinospiroma is rhinosporidiosis is a protozoa infection. Rhinospiroma is a bacterial infection. It is caused by Klebsiella rhinosporomatis, which is called as fish bacillus. It is having 3 stages. The first one is atrophic stage. The second one is granulomatous stage. Third one is cicatricial stage. The atrophic stage will resemble atrophic rhinitis. The granulomatous stage, there will be subdermal infiltration of granuloma, which is resembling Hebra nose. Cicatricial stage, there will be stenosis of the nasal cavity, tapir nose deformity. Okay, stenosis of the nasal cavity and then tapir nose deformity. On doing histopathological examination for this patient, there will be Mikulicz cells and Russell bodies. Mikulicz cells and Russell bodies. Okay. The treatment for this patient is streptomycin, rifampicin. Treatment for this patient is streptomycin and rifampicin. Deviated nasal septum. The nasal septum is supposed to be in the middle. If it deviated, it will cause nasal obstruction for this patient. If it is deviated to the left side, opposite side will work more. That will cause compensatory inferior turbinate hypertrophy. So, nasal obstruction can happen at both nasal cavities. So, very important then, there will be constant touching between the middle turbinate and the deviated nasal septum. That will cause Sludder's neuralgia or anterior ethmoidal neuralgia. The middle turbinate touching the nasal septum is called Sludder's neuralgia. So, deviated nasal septum is correct deviation by septoplasty or submucous resection of septum. Septoplasty, you will do a freeless incision. The age is less than 17 years. You remove only the deviated part. The problem is it could have some recurrence. But submucous resection of septum, Killian's incision, more than 17 years you should do. You remove almost the entire cartilage in septum and deviated bony septum. So the problem is if you remove too much, the patient can have saddle nose deformity. The patient can have saddle nose deformity. What are the other problems can happen in the nasal septum? So septal abscess is nothing but pus formation in the nasal septum. Hematoma is bleeding or blood collection in the nasal septum. So whatever be the cause, if one septum is affected, both areas can be affected. Both sides can be affected. So you should do incision and drainage as early as possible. If you don't do that, the cartilage which is having feeble blood supply can go for necrosis. Please don't do that. Do IND as early as possible. This question they may ask: systemic diseases affecting septum. If it is only bone erosion, it is tertiary syphilis. Cartilage erosion means it could be trauma or iatrogenic cause, infection, leprosy, or TB. You have to remember only tertiary syphilis, bone erosion. Both cartilage and bone erosion, it is vaginous granulomatosis. Okay, these two are very important. Please don't forget. Syphilis affects which part of the nose? Bony septum. A middle-aged man, saddle nose deformity with non-caseous necrosis. So if this non-caseous necrosis is seen in saddle nose deformity, there is some septum defect is happening. So non-caseous necrosis will happen in TB, caseous necrosis, syphilis, no necrosis and all, leprosy. So the answer could be vaginous granulomatosis. Okay, could be vaginous granulomatosis. If you have a doubt now, you could ask this question. Okay. The final part of nose is trauma to the nose. The trauma to the nose, the most common facial bone to get trauma is nasal bone. You feel over here. If the nasal bone goes for trauma, it could cause fracture nasal bone. It is the most common bone to get fractured among facial bones. There are two types of nasal bone fracture. One is chevrolet fracture. The next one is Jargevay fracture. Chevrolet fracture, the blow is from below. It causes vertical fracture line. Jargevay fracture, the blow is from front, horizontal fracture line. Okay. So blow is from the front, Jargevay fracture, below Chevrolet fracture. Now you look into this very important. If the patient is having nasal bone fracture, if he comes immediately, you don't do surgery. Undisplaced fracture, no deformity, please leave the patient. Small aerial crack, you don't have to treat the patient. If there is displaced fracture with deformity, like this is displaced fracture with deformity, okay? There is deformity present. If there is edema, you don't do surgery till 5 days. No surgery till 5 days, okay? Ideal is do 7 to 21 days. 7 to 21 days you could do. After 21 days, please don't do. So you do surgery before fibrosis and after edema. After edema, before fibrosis. 7 to 21 days you do surgery, which is internal closed reduction of nasal bone fracture. Closed reduction of nasal bone fracture. So how can you reduce the nasal bone fracture with closed approach? See, if you use a Walsham's forceps, this is a Walsham forceps, they may ask this picture-based MCQ. This hook-like thing, na ash forceps for nasal septum, midline. For the nasal bone fracture, you should use a Walsham's forceps. Okay. Leaford fracture. The facial polytrauma can be divided into 3 types of Leaford fracture: type 1, type 2, and type 3. Type 1, horizontal fracture segment just below the nose. Type 2, a pyramidal fracture segment involving the nasal bridge. Type 3, craniofacial disjunction, even the skull base getting affected. Okay. Craniofacial disjunction. The type 1, if the palate goes like this, it could cause a floating palate on imaging. Floating palate. The floating palate is called as Guerin sign. So leaf-foot fracture, any trauma over the face, polytrauma over the face, we divide into 3. 1 is over here, 2 is over here, 3 is completely skull base involved. Okay. Other facial bone fracture, nasal bone fracture we have seen leaf-foot fracture. Now we have to see about zygomatic fracture and fracture floor of orbit. Zygomatic fracture means tripod sign positive. Tripod sign positive. Fracture floor of orbit means it is otherwise called blowout fracture. There will be teardrop sign seen. There will be teardrop sign seen. Right? That is a condition called. If there is a fracture over the orbit, there will be traumatic optic neuritis that will compress the optic nerve. If the optic nerve just compressed now, you could relieve the compression by doing a surgery called optic nerve decompression. If you do the surgery as early as possible, as early as even 24 hours now, you could save the vision of the patient. You could save the vision of the patient. Okay. The last topic in nose is CSF rhinorrhea. It's a very important topic. They have asked a lot of questions from this. So CSF rhinorrhea can be a spontaneous CSF rhinorrhea, iatrogenic or traumatic. Spontaneous means due to obesity. Spontaneous means obese patient can have CSF rhinorrhea. Iatrogenic is due to surgery. Traumatic is due to some trauma. The spontaneous and iatrogenic is happening at cribriform plate of ethmoid. Very, very, very important. So cribriform plate of ethmoid is a very papery thin bone. It is getting involved in spontaneous and iatrogenic CSF rhinorrhea. Traumatic CSF rhinorrhea, little bit specific we could see now, fovea ethmoidalis, which is also near to cribriform plate of ethmoid, but to be specific now, it is fovea ethmoidalis. What are the investigations? The traumatic CSF leak or any CSF leak, you use a handkerchief. Handkerchief will not go for stiffening. If you are having a common cold, nasal discharge, if you use handkerchief, the handkerchief will stiffen due to nasal secretion. So nasal secretion na handkerchief stiffen, CSF secretion na handkerchief will remain the same. No stiffening of the handkerchief. Second one, there will be a small defect is present. So there will not be leakage present all through the day. The patient lies down, and again if we do like this now, it will come forward. So reservoir sign positive. Reservoir sign positive in maceratis and also positive here also. CSF rhinorrhea, after patient to lie down for 5 minutes, all the fluid get collected in the nasal cavity. Then if she bends down now, all the fluid will come down. Okay. So I will show you the reservoir sign positive. It's very monotonous. I am not showing you any video. That's why. See here. This is reservoir sign positive. Only bending forward, there will be leakage of CSF. Okay, this is reservoir sign positive. This is nasal bone fracture reduction with Waldsham forceps. Can you see? We are not putting any incision. We are just introducing the instrument, and we are just repairing the fracture site. This is nasal bone fracture reduction. Okay. So what are the other case rhinorrhea? If I collect the CSF fluid over a white handkerchief, the central part will be filled with red. The peripheral part will be filled with CSF due to change in specific gravity. Blood having more specific gravity, CSF having less specific gravity. So halo sign. This is called halo sign or double density sign positive. The gold standard investigation for CSF rhinorrhea is CT cysternogram. We will inject contrast and ask the patient to undergo CT scan. Now we will clearly see the defect site getting filled with contrast, CT cysternogram. Or you could do a intrathecal fluorescent dye. You could do a intrathecal fluorescent dye. CSF analysis can also be done. CSF analysis can be done with two parameters, beta 2 transferrin and beta trace protein. Beta 2 transferrin and beta trace protein. Alright. To do a CSF leak repair. To do a CSF leak repair. Okay. A few questions from this chapter. Doctor question ICU and came to ENT OPD. Loss of smell, loss of taste, no history of trauma. What is next step of punishment? This was a question from COVID era. So it's a nasopharyngeal swab for confirming COVID. The boy fell down while playing and presence in the deviate nose, which is a fractured nasal bone. Septum apicibula, there is presence in nasal bone fracture. Next step, flows reduction after edema subsides in 7 days. Okay, flows reduction and edema after edema subsides in 7 days. Lady comes to OPD after 12 months QT. Her vitals are stable. She is continuous clear water discharge from nose. Most likely feature is CSF rhinorrhea. Clear watery discharge from the nose is CSF rhinorrhea. These are the questions they asked from previous FGs. Okay. Enter into pharynx. The pharynx divides into nasopharynx, oropharynx, laryngopharynx. Laryngopharynx otherwise called as hypopharynx. Okay. So the anatomy of nasopharynx very important. Please make a note of it. This is an endoscopic picture of nasopharynx. I am focusing the posterior wall of the nasal cavity, nasopharyngeal cavity. What are the boundaries of the nasopharynx? What are the boundaries of the nasopharynx? First, the roof of the nasopharynx corresponds to skull base. Then, posterior wall corresponds to vertebra. The lateral wall corresponds to three structures: fossa of Rosenmuller, torus tubaris, eustachian tube opening. Okay, fossa of Rosenmuller, torus tubaris, eustachian tube opening. So these three are the lateral wall structures related with nasopharynx. So anteriorly it relates with nasal cavity. Inferiorly, it continues as oropharynx. Anteriorly, nasal cavity. Inferiorly, oropharynx. Okay. So what are the diseases that are associated with nasopharynx? The first one is JNA, juvenile nasopharyngeal angiofibroma. Very important. It's a benign tumor, completely encapsulated tumor, but the encapsulation is having some contractile material. That's why it is very much vascular tumor. So it is present in adolescent males. It will cause profuse epistaxis. He will be having nasal obstruction and the patient will be having frog face deformity. What is the commonest site? Sphenopalatine foramen. The hormone that is thought to play a role in GNA is testosterone hormone. The hormone is testosterone hormone. The investigation we could do is CT facial bone showing Holman-Miller sign. CT facial bone showing Holman-Miller sign. Okay, fine. See, pushing of the tumor. This is the tumor which I am talking about. This tumor, after occupying pterygopalatine fossa, it is pushing the maxillary sinus from behind. Okay, pushing of the posterior maxillary is called as Holman-Miller sign. Very, very important. Treatment: surgery. Radiotherapy can be done only if it is intracranial spread. Okay, JNA has been done and dusted. Second one is malignant tumor of the nasopharynx. That is also very important. Carcinoma nasopharynx. Okay, carcinoma nasopharynx. So, when we consider the etiology, it is more common in Chinese population. It is more common. Okay, then it's caused by Epstein-Barr virus, EBV. There will be a correction in your workbook. You could kindly correct it. Epstein-Barr virus. What is the HLA associated? HLA B7. Okay, the commonest site of CA nasopharynx is fossa Closer-Muller. The most important aspect of CA nasopharynx is you know very well about the anatomy of nasopharynx. Now you look at the anatomy of nasopharynx. From this, the tumor can go into the skull base, into the vertebra, into the nasal cavity causing nasal obstruction epistaxis, into the oral cavity causing neck nodes positive. So these are the spread patterns and clinical features. So above skull base metastasis, behind vertebral metastasis, anteriorly nasal obstruction epistaxis, below into the oral cavity painless cervical lymphadenopathy. The painless cervical lymphadenopathy is the most common presenting symptom. Okay, most common presenting symptom is painless cervical lymphadenopathy. Then lateral wall, it could block the, I have told you already, serous otitis media. The causes are two: in children, adult hypertrophy; in adults, it is carcinoma nasopharynx. So carcinoma nasopharynx, it could cause serous otitis media, causing connective hearing loss. So what is sinus of Morgagni? Sinus of Morgagni is space between superior constrictor muscle and skull base. Okay, between superior constrictor and skull base. Okay, if the tumor involves this particular space called sinus of Morgagni, the patient will have Trotter's triad positive. Okay, Trotter's triad positive. In Trotter's triad, there will be temporoparietal neuralgia, palatal palsy, connective hearing loss. Very, very, very important. Trotter's triad, they may ask. Temporoparietal neuralgia, palatal palsy, and connective hearing loss. Other triads, they may ask is Samter's triad. Aspirin insensitivity. This is seen in nose. Bronchial asthma. And nasal polyp. So this is Samter's triad. So Trotter's triad and these two are the only triads they may ask in ENT. Trotter's triad is due to CNS suffering. Samter's triad is due to some nasal pathology, sinusitis. Okay, what? So type of tympanometric graph seen in carcinoma nasopharynx. It will cause serous otitis media. If it is serous otitis media, that is type B curve. Okay. The best treatment for carcinoma nasopharynx is radiotherapy. Alright. The third important benign pathology of nasopharynx is adenoid hypertrophy or nasopharyngeal tonsil hypertrophy. So adenoid tissue is otherwise called nasopharyngeal tonsil only. Type of epithelium of adenoid is, so this is the adenoid tissue. The adenoid is enlarged like this. It will cause nasal obstruction and will cause adenoid feces. The patient, instead of breathing through the nose, breathe through the mouth. The chronic mouth breathing and snoring will cause the feces such as adenoid feces. The patient will have high arched palate, crowded maxillary of teeth, loss of nasal labial fold, pinched up nostrils, sunken eyes, pursed lip breathing, elongated face, short upper lip, hypoplastic maxilla. So these are the features of adenoid feces. Features of adenoid feces. Okay. Now the second important part of pharynx is deep neck spaces and deep neck spaces infection. See here, basically we are dividing neck spaces into based on fascia. We are having superficial cervical fascia, deep cervical fascia. The superficial cervical fascia completely engulfs the platysma. Okay. Deep cervical fascia divided into three parts: superficial, middle, and deep. We are having other names for these three respectively: investing line of deep cervical fascia, pretracheal fascia, and then prevertebral fascia. So superficial, middle, and deep. So what is important in this, sir? We are having a lot of spaces formed by these fascias. See here, we are having vertebra. In front of the vertebra, we are having prevertebral space. Between the prevertebral space, this is prevertebral space. So the prevertebral space is found behind the prevertebral fascia. See here, that is very, very important. So prevertebral fascia. Okay. So between the prevertebral fascia and alar fascia, between the prevertebral fascia and alar fascia, we are having a space called danger space. Between the alar fascia and buccopharyngeal fascia. Very important part. They are having a space called retropharyngeal space. See, in front of vertebra, prevertebral space number 1. Between the prevertebral fascia and alar fascia, danger space. Between alar fascia and buccopharyngeal fascia, retropharyngeal space. So 3 spaces are very important. If it is getting involved, if it is getting infected, it can cause a lot of complications for the patient. Okay. So if the retropharyngeal space can go for infection, it could cause retropharyngeal space abscess. In acute retropharyngeal abscess, the patient can have dental caries, penetrating neck trauma. In chronic retropharyngeal abscess, the cause can be TB spine. Cause can be TB spine. Okay. Investigation of the retropharyngeal abscess is widening of prevertebral shadows. Prevertebral shadow widening. Okay. X-ray neck lateral view showing prevertebral shadow widening. Treatment for retropharyngeal abscess is incision and drainage under local anesthesia in sitting position. The patient will be having posterior pharyngeal wall which is filled with pus. If you do a general anesthesia, the endotracheal tube may puncture the site. So to avoid that, you should do the incision and drainage in a sitting position. Okay. Next one is parapharyngeal space abscess. The parapharyngeal space abscess is having 2 compartments. One is pre-styloid compartment. Second one is retrostyloid compartment. So pre-styloid compartment, there will be medial bulging of tonsil. We could do an intraoral drainage. Retrostyloid compartment is very, very important. It could cause involvement of cranial nerves 9, 10, 11, sympathetic plexus. Carotid artery may also be involved. External drainage. Okay. So anatomy and blood supply of tonsil, the patient can have descending palatine artery from maxillary artery, ascending pharyngeal artery, ascending palatine artery, and tonsillar branches from facial artery, tonsillar branches of lingual artery. Ascending palatine and tonsillar branches from facial artery, tonsillar branches of lingual artery. Okay. So Valdes ring is a group of lymph nodes that are grouped with each other. So inner ring and outer ring will be there. The inner ring is formed by nasopharyngeal tonsil, number 1, tubal tonsil at the tongue. Tubal tonsil is the actual tonsil. Then palatine is at the palate, lingual tonsil at the tongue. So these 4 tonsils will form a circle of lymphatic structures. That circle is called as Valdes ring. So first we know adenoid. This is tonsil. We know this tubal and lingual alone. You remember, you could understand a concept called Valdes ring, which is a circle of lymphatic tissue. So very important, tonsillitis. The tonsillitis, it could be bilateral, could be acute or chronic. Acute, you give acute antibiotics and manage the patient conservatively. Chronic tonsillitis, having episodes more than 6 episodes per year, you do tonsillectomy surgery. Whereas peritonsil abscess, it's not bilateral, it is always unilateral. Pus collection due to some infection happening between the superior constrictor muscle and the capsule of tonsil. You do an incision drainage and you do a interval tonsillectomy after 4 to 6 weeks. Okay. The next important differential diagnosis is differential diagnosis for membrane over tonsil. It could be due to membranous tonsillitis, diphtheria, infectious mononucleosis, aphthous ulcer, agranulocytosis, leukemia. They may ask this question. It's a very important topic. Differential diagnosis for membrane over tonsil. Ludwig's angina is nothing but submandibular space abscess. There will be mixed bacterial infection happening. It occurs in immunocompromised individuals. It is rapidly progressive and patients may present with stridor, may need tracheostomy. So it's nothing but a submandibular space going for infection, causing entire swelling of the neck. So there is a mixed bacterial infection. The patient will be having an immunocompromised type 2 diabetic uncontrolled. So if you don't treat it adequately on day one itself, the patient can go for stridor. You may need tracheostomy also. So larynx. So larynx anatomy is very easy and simple. We are having 3 paired cartilages, 3 unpaired cartilages. The unpaired cartilage number 1 is thyroid cartilage. It's a shield-shaped cartilage. The thyroid angle is very important. So 90-degree in males, that's why Adam's apple is present. So males, there is prominence because it is 90-degree. Whereas females, it is quite obtuse angle, 120-degree. So the superior cornu will contact with the hyoid bone. Inferior cornu with contact with the cricoid cartilage below. The second unpaired cartilage is cricoid cartilage. It is a signet ring shape and it is a complete cartilage. It's a complete cartilage. Okay. Next one is epiglottis cartilage. It is a leaf-shaped cartilage. It is attached to the midline in the thyroid lamina. So epiglottis will close and open the airway. So this will prevent aspiration. Very important cartilage. So these 3 cartilages are unpaired cartilages. Okay, unpaired cartilages. So what are the paired cartilages? Arytenoid, cornicate, cuneiform. Cornicate, cuneiform, no much. Nothing to do, nothing clinically significant. But arytenoid is very important cartilage. This cartilage is necessary for vocal cord movement. Okay, if the vocal cord moves to the midline, away from the midline, the cartilage that is behind it is arytenoid cartilage. It is arytenoid cartilage. So the laryngeal inlet is formed by laryngeal surface of epiglottis, aryepiglottic fold, and then interarytenoid area. So just think of that. So what is the laryngeal inlet? You look into this 3-dimensional picture. So this is an epiglottis cartilage. Okay, this will close the airway like this. Now in this epiglottis cartilage, this is the free surface of epiglottis. This is the aryepiglottic fold. This is the interarytenoid area. Thus it forms a complete circle. This complete circle we call it as laryngeal inlet. The entry point for larynx starts here. Okay, so this is the laryngeal inlet. When we enter into the larynx, you could see the vocal cords like this. Can you see? This is true vocal cords. This is false vocal cords, otherwise called vestibular fold. Between the 2 vocal cords, we will be having a ventricle which is filled with saccule, which is the oil can of larynx. So these are the important anatomical points of larynx. So laryngeal inlet, I have told you, epithelium of larynx is mostly formed by ciliated columnar epithelium except epiglottis, superior border of false cord, and true vocal cord. Okay, and true vocal cord. Okay, so these three are the areas which are filled with stratified squamous epithelium rather than ciliated columnar epithelium. This is filled with stratified squamous epithelium. So something about membranes of the larynx. The membranes of the larynx can be intrinsic membranes and extrinsic membranes. Okay. The functions of the larynx are mainly respiration, phonation, fixation of chest, and protection of lower airways. Very important. Now, what are the intrinsic membranes? What are the extrinsic membranes? So we are having three unpaired cartilage, 3 paired cartilages. So this is the premises of the larynx. If a membrane starts from the larynx, end at the larynx, it is called intrinsic membrane. If a membrane starts at the larynx, end outside the larynx, we call it as extrinsic membranes. Very easy. So quadrangular membrane and conus elasticus will start and end within the larynx, whereas hyoepiglottic ligament, trichotracheal ligament, membrane and thyroid membrane will start from the larynx, will end outside like hyoid bone, tracheal ring, or hyoid bone. If it ends outside, now it is an extrinsic membrane, very easy to understand. We are having two spaces, a paraglottic space and a pre-epiglottic space. Where paraglottic space is found adjacent to the glottis, pre-epiglottic space found in front of the epiglottis, which is filled with only fat. Okay, so it is found behind the hyoid bone and thyroid membrane. In front of epiglottis, it's just filled with fat. That is pre-epiglottic space of Boyer. Now, what is the difference between infant larynx and adult larynx? The infant larynx, it is at C2 to C2 C3 level of vertebra. The adult larynx is at the C6 level of vertebra. Okay. The epiglottis is flexible in infant. The epiglottis is stiff in an adult. The epiglottis is stiff in an adult. The most important point among all these are the narrowest area of infant larynx is subglottis. The narrowest area of adult larynx is glottis. Okay. The narrowest area of infant larynx is subglottis. The narrowest area of adult larynx is glottis. Okay. I have two topics remaining. Okay. So I'll have only 1 minute break. So what is over, and have 1 minute break. I'll come back. The last part of our discussion. We'll have only around 10 to 15 minutes of discussion, and then we'll leave. Okay. And we'll go faster, but time work also, but I can't do that. We explain a little bit, showing some anatomy only now, I'll feel satisfied. Okay. So, over 1 or 2 of you medicine, I don't care, but it should be complete. Okay, it should be useful for you, no? So, vocal fold muscles, they are having two muscle activity. So, this is a vocal cord. From the vocal cord cadaveric position, this is abduction, this is adduction. This is abduction, this is adduction, which is very important. So, abduction means away from the midline. So, there is adequate space between the vocal cords. For living, we need abduction. So, only abductor muscle that we know is posterior trichorhypnoid. Okay, so we call it as safety muscle. Safety muscle of larynx is called as posterior trichorhypnoid. Okay, posterior trichorhypnoid. Then tensor muscles of the vocal cord, vocalis and then cricothyroid. Adductor muscles are very many muscles are there. Lateral cricoid, transverse thyroid, many are there. But the most important muscle is abductor muscle, posterior cricoid. Now, the course of the vagus nerve. Vagus nerve course is very important. It comes out of jugular foramen. Superior laryngeal nerve is given at the level of neck itself, but the recurrent laryngeal nerve is given at the level of thorax only. After giving at the level of thorax, it will come again above into the neck. So that's why it is called as recurrent. It's not given up directly at the neck. It will be given up at the level of thorax. It will recur above and then supply the neck. It is called recurrent laryngeal nerve. So the recurrent laryngeal nerve acts around arch of aorta on the left side and subclavian artery on the right side. Okay. So what is the difference between superior laryngeal nerve and recurrent laryngeal nerve? The sensor is applied till the level of vocal cord. Sensor is applied below the level of vocal cord. That's the difference between superior laryngeal nerve and recurrent laryngeal nerve. All the muscles of the larynx except cricothyroid are supplied by recurrent laryngeal nerve. Very, very important. Please don't forget. Whereas cricothyroid, which is a tensor, but little bit of adduction also happens. Cricothyroid. Position of the vocal cord just adjacent to the midline. Paramedian position is 1.5 millimeter from the midline is paramedian position. 3.5 millimeter from the midline is carotid position. 7 millimeter gentle abduction. 9.5 millimeter full abduction. These are the positions of the vocal cord. Okay. Causes of vocal cord palsy. The superior laryngeal nerve palsy and both superior laryngeal nerve, recurrent laryngeal palsy can happen mostly in sinus lesions. Okay. So mostly both nerve palsy and superior laryngeal palsy happens in sinus lesions only. But recurrent laryngeal palsy mostly due to local pathologies such as CA thyroid or total thyroidectomy. So local pathologies mostly affect the recurrent laryngeal nerve. Mostly it will seldom affect the superior laryngeal nerve. Okay. The important thing is if it is both side recurrent laryngeal nerve palsy, it could be a thyroid surgery, carcinoma thyroid. Carcinoma is a regular cervical nephropathy. It's easy to remember. If it is only left-sided, there will be left-sided causes different, right-sided causes different. So it may be an aortic arch aneurysm because it is adjacent to the aortic arch. Left atrial enlargement because it is adjacent to left atrium. It is Ortner's syndrome or mediastinal lymphadenopathy. Only left-sided oral palsy, these are the causes. Only right-sided oral palsy, carcinoma upper thorax is the cause. Both palsy, both side can happen. These are the causes. So what are the nerve palsies and what are the features? What are the treatment we can see? Only superior laryngeal palsy, the patient will have only cricothyroid affected. If cricothyroid affected, there will be huskiness of voice. If sensor is applied till the level of vocal cord affected, there will be aspiration, mild aspiration. Here, severe aspiration. Here, severe aspiration. Unilateral superior laryngeal nerve palsy. Unilateral superior laryngeal nerve palsy, don't do anything because other side is normal. Conservative treatment. Bilateral superior laryngeal nerve palsy, the patient will be having normal respiration because no muscle is affected, only cricothyroid. So cricothyroid will cause only huskiness. But sensory supply is affected, severe aspiration. For avoiding severe aspiration, you should do tracheostomy with feeding tube or epiglottic pexy with tracheostomy. See, can you understand me? Superior laryngeal nerve palsy, superior laryngeal nerve supplies only cricothyroid and sensory supply to the level of vocal cord. So if there is no sensory supply to the level of vocal cord, if saliva reaches there now, it could go into the lungs because there is no sensation. So aspiration pneumonitis it could cause and huskiness, very easy. Recurrent laryngeal palsy, otherwise called bilateral aorta palsy. Okay. So unilateral recurrent laryngeal palsy, the respiration will be normal. The patient will be having hoarseness of voice. Okay. And also the position will be unilateral paramedian position. Just look into the bilateral recurrent laryngeal palsy. The patient will be having paramedian position of the both vocal cords. It is stridor. Severe hoarseness of voice will be there. And the position will be bilateral paramedian position like this. The treatment part for bilateral recurrent laryngeal palsy very, very important. As the cords are in paramedian position, you should make the cord move away from each other. You could do a lateralization suturing or lateralization thyroplasty, or you could remove a part of the posterior half of the vocal cord by a cordectomy procedure called Dennis-Keshima procedure. So type 2 thyroplasty or lateralization thyroplasty or lateralization suturing, reinnervation procedure or Dennis-Keshima procedure. Dennis-Keshima procedure is nothing but we are removing one side posterior half cord and ulnar process. So that will create some space for breathing. This patient, the vocal cords are in midline, now no space for breathing. Such is the cause we could do this procedure. Okay. Now next one is both nerve palsy. Both superior angina and recurrent angina goes for palsy. What will happen? The vocal cords will be in cadaveric position. No abduction, no adduction. The patient will be in cadaveric position. So breathing will be normal because cadaveric position will have ample space for breathing. But if the vocal cords can't meet each other in the midline, there will be dysphonia happening. Unilateral both nerve palsy, dysphonia. Bilateral both nerve palsy, no meeting at all, aphonia. See, respiration will be normal, but speech will be completely abnormal. Position unilateral cadaveric. This is bilateral cadaveric position. So the space is adequate for breathing, but not adequate for voice production. So treatment for unilateral both nerve palsy, you push the vocal cords to the midline, which is type 1 thyroplasty or medial thyroplasty. So bilateral na, you could do vocal cord plication to avoid, because there will be severe aspiration happening. Because both nerves gone no. Severe aspiration, you do a vocal cord plication or tracheal diversion procedure. Vocal cord plication or tracheal diversion procedure. Okay. So vocal cord disorders. So when we see about the histopathology of vocal cord, outer will be the squamous epithelium. Below will be 3 lamina propria. Lamina propria superficial, intermediate, and then deep lamina propria. Okay. So below will be the vocalis muscle. So this is the histopathology of this vocal cord. If you want to diagnose some benign pathology of the vocal cord, we should do a test called video stroboscopy. This is based on the principle that we can't normally see the minute vibrations in the vocal cord because the small vibrations can't be seen on naked eyes. Whereas if we give flashes of the light that is on par with the vibration of the vocal cord, that can be seen as a vocal cord vibration. That is called video stroboscopy. It's based on a principle called Tablott's law. Okay, Tablott's law. Okay, so what are the voice disorders? Adductor dysphonia is nothing but larynx is normal, but adductor muscle goes for spasm. Two types: spasmodic dysphonia, functional dysphonia. So the adductor dysphonia is nothing but strained voice. Two types: spasmodic dysphonia, muscle tension dysphonia. It's due to some CNS pathology. Functional dysphonia is due to some emotional outburst. Abductor dysphonia. So abductor dysphonia, the muscle apparatus posterior cricoid causes unknown. So under electromyography, Botox injection into posterior cricoid can be done. Type 1 thyroplasty. Okay. So adductor dysphonia, abductor dysphonia. This was just for theory point. Nothing much to understand. Dysphonia plica ventricalis, voice is produced from false vocal cord instead of two vocal cord. So the voice will be low pitched, rough, and unpleasant. Treatment is speech therapy. Okay. So low pitched, rough, and unpleasant voice. The voice is produced from false vocal cord instead of true vocal cord. The treatment is speech therapy. Contact ulcer. Ulcer and granuloma over posterior thirds of vocal cord and arytenoid is called contact ulcer. The patient will have constant desire to clear the throat. Okay. If the cause is voice abuse, the treatment is speech therapy. If the cause is gastroesophageal reflux disease, it is proton pump inhibitor. The granuloma formation due to intubation is called as intubation granuloma. You should give steroids. See, contact ulcer, intubation granuloma, you could give speech therapy if it is vocal abuse. Proton pump inhibitors if it's a GERD. Steroids if it is a intubation granuloma. Sulcus vocalis, a small furrow running parallel to the edge of vocal cord is called sulcus vocalis. The treatment for sulcus vocalis is injection laryngoplasty. Injection laryngoplasty. So puberphonia in adolescent males, female voices present, it is called puberphonia. It is clinically confirmed with Gutzman pressure test. Nothing but we compress the cartilage like this. Suddenly, the male with the female voice will regain the male voice. So there is no much adequate pressure over the vocal cords. That is the reason the boy is having female voice. So this is found by Gutzman pressure test. The treatment is thyroplasty, type 3 thyroplasty. Okay. Androphonia. Androphonia is seen in females. The treatment is type 4 thyroplasty. So Ishiki thyroplasty, the type 1 is abductor dysphonia and unilateral both nerve palsy. Type 2 is bilateral abductor palsy. Type 3 is puberphonia. Type 4 is androphonia. Some benign diseases of the vocal cord, it could be vocal nodule or vocal polyp. Vocal nodule is at the junction of posterior 2/3 and anterior 1/3 that causes voice abuse. The vocal nodule is otherwise called singer's nodule or teacher's nodule. The singers and teachers who used to shout like anything, they will get this nodule. Okay, so please don't abuse your voice. If you abuse the voice, you may get vocal nodule. The site is junction of anterior 1/3 and posterior 2/3, causes voice abuse, mostly bilateral. Treatment is conservative. You give voice rest for 6 weeks. Vocal polyp is due to smoking or allergy. It occurs at the junction of anterior 1/3 and posterior 2/3 of the vocal cords. The cause of smoking or allergy is mostly unilateral, but the treatment is microlaryngeal excision surgery. Okay, so treat the patient with surgery. Reinke's edema. The superficial lamellopropia, vocal cord histopathology, I have already told you. Epithelium, then superficial lamellopropia, intermediate and deep lamellopropia. With the superficial lamellopropia, which is not filled with much of anything, collagen or fat. So if it is completely filled with some edema, it will cause Reinke's edema. So the superficial lamellopropia is otherwise called as Reinke's paste. That's why it is called as Reinke's edema. The cause is hypothyroidism, smoking. Very, very, very important. Hypothyroidism, smoking. Treatment is decortication of the cystic swelling. Vocal cord papilloma, adult papilloma is most recurrent. Juvenile onset papilloma is less recurrent. Agents to reduce the recurrence, you could use alpha interferon, bevacizumab, cidofovir, and ribavirin. Okay, these are the diseases that is associated with vocal cord. Very, very important. Now, some diseases about larynx. So, if it is an acute infection of epiglottis, is called acute epiglottitis. The important sign is thumbprint sign, seen on X-ray lateral view. It is caused by Haemophilus influenza virus or pneumococcus. Previously, Haemophilus has more incidence. Now, pneumococcus has getting more incidence. Croup is caused by parainfluenza virus A, parainfluenza virus B. Radiological sign is steeple sign. Okay, radiological sign is steeple sign. This is steeple sign or church top sign. Very, very important. Acute epiglottitis, thumbprint sign. Croup or acute laryngobronchial bronchitis, you will have steeple sign or church top sign. So the clinical sign in epiglottitis is tripod sign. Here there is steeple sign only. Treatment is give adequate hydration, give antibiotics. If the patient is having stridor, do a tracheostomy. So laryngosele is nothing but a small diverticulum from the ventricle of larynx called saccule. Between true vocal cord and false vocal cord, there is a space called ventricle. In the ventricle, you will have a space called saccule. If the saccule herniate due to too much pressure by the trumpet blower, some blow instrument, laryngosele happens in persons using blow instruments. Okay, using blow instruments. A small diverticulum from the ventricle of the larynx is called saccule. So it is internal laryngosele and external laryngosele is there. It is clinically demonstrated by Valsalva maneuver. If you hear gurgling sound over the swelling, it is called Bryce sign positive. If symptomatic, do surgical excision. Laryngosele, trumpet blower or any blow instrument, they have asked this question a lot of times. So you do surgical excision only if symptomatic. They may ask this question, Valsalva maneuver and then Bryce sign. Killian's dehiscence. A natural dehiscence found between cricopharynx and thyropharynges of inferior constrictor is called as Killian's dehiscence or Killian's triangle. If the patient experiences herniation of pharyngeal mucosa through this Killian's dehiscence, is called as pharyngeal pouch or otherwise called Zenker's diverticulum. Okay, so in this pouch, it's a barium swallow image. In this pouch, if some food particles getting accumulated now, gets accumulated, goes for some putrefaction. When the patient lies down, it can come out. It can come out. That will cause halitosis and aspiration pneumonia. Halitosis and aspiration pneumonia. The treatment for this pharyngeal pouch is Dolman's excision. The treatment for pharyngeal pouch is Dolman's excision. Okay. Laryngomalacia. It's nothing but most common cause for neonatal stridor. The epiglottis is going for some flexible state. Okay, the most common cause of neonatal stridor, the shape of epiglottis in laryngomalacia is omega shaped. Shape of epiglottis in laryngomalacia is omega shaped. Okay, fine. TB larynx, there will be pale laryngeal mucosa, turban epiglottis, mammalian appearance of interretinoid, mouse nibble appearance of vocal cord. These are just theory points. You just read it. Okay, nothing to explain. TB larynx, these are the signs in TB larynx. The classification of congenital subglottic stenosis is by Cotton-Meyer staging. Okay, grade 1 is up to 50% obstruction, grade 2 up to 70%, grade 3 up to 99%, complete obstruction is grade 4. Okay, fine. So last part of larynx is malignancy. The most common cause of laryngeal stridor in 60 years male is, so if it is a non-sephageal carcinoma, it will not cause stridor, it will cause stutter. The first point. Acute severe asthma will not cause stridor, it will cause wheeze, noisy lung sounds. Dengue edema don't have any stridor. The answer is cause larynx. But how to approach this question, I'm just telling. Nasopharyngeal tumor will not have any stridor, have only stutter. Severe asthma, some other sounds. Only the larynx lesion will be having stridor. Inspiratory stridor, supraglottis. Expiratory stridor, subglottis. Glottis, both inspiratory stridor and expiratory stridor. So what is the etiology of carcinoma larynx? Tobacco, alcohol, sulfuric acid. What is the true statement about the glottic carcinoma? See, we are having 3 types of carcinoma. One is supraglottis, glottis, and subglottis. Supraglottis will be having dysphagia. The most common lymphatic spread, very important, because glottis, though it is most common type, it will not have any lymphatic spread, zero lymphatic spread, because vocal cord is not having any lymphatics. So more common for lymphatic spread, supraglottis. More common tumor is glottis. Subglottis, nothing important. Okay. So now, where it will happen? It happens in more common in not females, more common in males. It is usually seen over 50 years after laryngeal. So glottic carcinoma is having good prognosis, because once removed, it will not recur. The answer is just not true. It's not more common in females, it's more common in males. It's usually seen 50 years of age, males, smoking, tobacco, everything. Okay. Now, what is the treatment for? What is the staging for CA larynx? T3 means vocal cord palsy. T4A means cartilage involvement. You just remember this point. This is the only point they will ask. Okay. So based on these two, you could answer the staging question. For nodal staging, N1 is less than 3 centimeter. N2 is 3 to 6 centimeter. N3 you just divide into N3A, N3B. More than 6 centimeter is N3A. Extra nodal spread is N3B. Okay. N2 also divided to N2A, N2B, and C. That's not very important. But N3A, N3B, N3B is extra nodal spread. Very important. So this is staging question for carcinoma larynx. The treatment is total laryngectomy and post-op radiotherapy. This is for T3, more than T3 you should do this. If it is T1, T2 now, you do only radiotherapy, you should preserve the voice. Okay, very important. Carcinoma larynx. Okay. So they have asked a lot of questions from the imaging, X-rays, CTs. They have asked a lot of questions. Okay. So X-ray nose, if we open the mouth and take an X-ray, it is called X-ray nose occipitomental view. Okay, or otherwise called Waters view. It's called as Waters view. We will see all the sinuses. Okay, so spinal sinus through the mouth opening we'll see. So Waters view is the view where we see all the sinuses. The next one is Caldwell's view. This Caldwell's view is mainly for frontal sinus. The Townley's view is for anterior cranial fossa. Okay. CT penis. See, in CT penis, you will see this is the inferior turbinate, this is the middle turbinate. Very, very important. Inferior turbinate. Middle turbinate. Okay. So there are few variations in the CT penis. So see here, the superior turbinate is here. The superior turbinate is pneumatized. Now it is called as pneumatized superior turbinate. And also the structures are pneumatized like this. This is pneumatized middle turbinate is concha bullosa. Concha bullosa. So inferior turbinate will not go for pneumatization. Okay. Now, named ethmoidal air cells. The most constant and consistent air cell, ethmoidal bulla. Infraorbital cell is called Haller cell. Posterior most cell near to optic nerve. Posterior most cell is called as monody cell. They may ask this question, very important. So infraorbital cell, Haller cell. Consistent cell, ethmoidal bulla cell. Anterior most cell, agar nasi cell. Okay. This is a picture of chronic sinusitis. So the entire nasal cavity and sinuses are filled with opacity. After doing stress, this is the picture. So everything is removed. Okay. This is a picture of allergic fungal rhinosinusitis. I have told you already. This is not uniform opacity. This is heterogeneous opacity. They ask this question, very important. Heterogeneous opacity. Can confirm with allergic mucin seen on endoscopy. Okay, allergic mucin seen on endoscopy. See here, this is a case of antrochoanal polyp. Polyp coming out of the antrum, reaching till the choana. This is a bilateral ethmoidal polyp. This is again post phase. After doing surgery, all polyp is removed. Okay. Some can cause bone erosion. Okay. 70 years male, unilateral nasal obstruction, foul smelling discharge. With this finding, you could think of inverted papilloma. Okay. This question they may ask: biphasic stridor. Given X-ray image. This is the X-ray image they have given. Okay. This is acute laryngotracheal bronchitis, steeple sign. Or church top sign. So foreign body throat, very important. The foreign body throat, if it is seen over here, it means that it got stuck. If in case of trachea or mediastinum, it will not get stuck. Okay. It is stuck only at esophagus or cricopharynx. If such question is asked, you should write up this answer only. So what can we do with foreign body? If a patient comes to you with foreign body, what shall you do? First, you could first, if it is present at the oral cavity, if it's suspicious, you put the fingers on the mouth of the child. This is done for only children. Sweep with fingers. It's for only babies. Then this one is has entered into the throat. The child is experiencing choking episode or cyanosis. Okay, you give chest compression with fingers and back slap. This foreign body will cough out. Foreign body will cough out. This is seen as adults. He's definitely choking now. You should do Heimlich maneuver. It has entered into the esophagus now. You do esophagoscopy. Has entered into the bronchus now. You do a bronchoscopy. That is the final treatment that can be given for this child. Very important topic. They may ask anything. A child presents with sudden breathlessness, strident tachypnea. What is the immediate investigation? So what you should do immediately? You should take an X-ray and find the foreign body. Sudden breathlessness, strident tachypnea. X-ray and find the foreign body. Young male sudden developed choking episode by eating in the restaurant. What will do next? Heimlich maneuver. Okay. Fine. That's all. The last page, some random questions you may solve by yourself. So I've given you almost all the topics without any discrepancy. So you could solve any questions from this. Okay. So in case of any doubt, you may ask me. Any doubt is there? Dr. Ilangovan, Dr. Chan, Dr. Mohanavale. Do you find any doubts? Shall I close the session? With this, you could answer 90-95% of questions from ENT.